introduce,
Yes,
ma'am?
yes, sir, we are live now.
Yeah.
Good evening, sir. Good evening.
वेलकम डॉक्टर जितेंद्र.
Good evening, madam.
गुड इवनिंग सर. आप डॉक्टर जितेंद्र अपना नाम रीनेम कर लीजिए या साहित्य यू डू एट योर ओन एंड. डॉक्टर
Madam, we
जितेंद्र.
are live now.
मैडम मैं मोबाइल से ज्वाइन कर.
हाँ हाँ. थैंक यू. सो बबीता, साहित्य यू स्टार्ट. सुमन.
Yeah, ma'am. We are live now and we are starting the program. So, good evening, doctors and all the participants. I am Dr. Suman from medical team of Field Healthcare. Welcome you all in this academic session. It's classic for clinicians, PPH and race. And it is organized under the aegis of societies of Baroda, Bapu, Valsad, Nadiad, and Palanpur. So now it's time to introduce the coordinator of the session. Saiti, can you please share the seat? Yeah, convener of the session, Dr. Babita Supla, Madam Bidhar MS OBGN, and she is the presently scientific secretary, ISOPAR Gorakhpur chapter. She is the vice president, Gorakhpur Option Time Society, and secretary, Women Doctors Association, Gorakhpur. And in terms of awards and all, she received many awards, out of which honors and gold medals in undergraduate. And in terms of publication, Madam did many publications in international journals of well repute. And in terms of special interest, she has a keen interest on high risk obstetrics, fetal medicine, and obstetrics and ultrasound. So, I think, can you move forward? Yeah. So, with this short introduction, I request Madam to take over the session for further questions. Thank you very much, ma'am. And over to you.
Thank you so much for your kind words. So, very warm welcome to all of you. My warm welcome to the societies of Baroda, Valsad, Vapi, Nadiad, and Palanpur to a series of E-Classic for Clinicians, PPH Skill and Drill. We all know PPH is the major cause of maternal mortality, taking to an account of almost 27%. So we should be all aware of the various skills and drills involved in management of PPH. Earlier, we had very little to do. We would give uterotonics, and if it failed, everything would go helter-skelter, and then we would land up in obstetric hysterectomies. But now we have better management protocols, be it the good uterotonics like carbetocin, and we have the bundle approach for better management of PPH. And before resorting to obstetric hysterectomies, we have so many other things to do, be it the compressive maneuvers, aortic compression, bimanual compression, or use of NSG if the patient is in shock, uterine balloon tamponade, different devascularization procedures, use of SR cannula, which sir will be demonstrating today, and internal iliac artery ligation. So it is like every one of us should be at least aware of these procedures to save our skin in this era of consumer forum. So let's begin our session, first of all, by remembering Ma Saraswati to bless this evening so that our webinar runs very smoothly. And let us also join hands for the lighting of the lamp. May the light of knowledge drive away the darkness of ignorance. With these words, I would like to talk about Dr. Sadhana Gupta ma'am. Madam has been working tirelessly since months to carry out these webinars in each and every district of our country, be it north, south, east, or west. We have conducted so many webinars till now, and yet we wish to conduct still many more so that most of the societies are aware of the different protocols in PPH. So let me invite Sadhana ma'am. Ma'am is co-chair Suffolk NCD committee, Foxy representative to Suffolk 2018-21. She has been vice president Foxy 2016, Madam has received 4 times ACIG, AICOG research paper,
Okay,
3 times
but
Korean award.
it's
She has
okay.
organized so many conferences, recipient of so many awards, and she has held almost every important key position in different organizations. And above all, she is the most deserving candidate, Foxy presidential candidate for the year 2023. A very warm welcome to you, ma'am. I invite you and I would request you to invite and introduce our chief guest of the day, Dr. Deepak Bhagre and Dr. Vineet Mishra. A very warm welcome to you, ma'am.
Thank you, Babita. And first of all, a very good evening and gratitude to office bearers of Baroda, Vapi, Valsad, Nadiad and Palanpur Society, Dr. Amita Shah, Dr. Sanjay J. Potedar, Dr. Kshittis, Dr. Vaibhav, Dr. Shailaja, Dr. Prajesh, Dr. Gaurav Gandhi, Dr. Pinky, Dr. Paresh, Dr. Shilpi, Dr. Girdhar Bhai, Dr. Dhaval, and Dr. Dignesh, because only your efforts and your coordination could make it that we are today here together for this very, very like important ongoing series. So it is around 60th series which we are having with the E-Classic for Clinician. And what is the base, what is suggested by just now Dr. Deepak Bhagre is concerned, actually, Dr. Deepak, that we are having so much of knowledge, but actually sometimes every clinician is like confused that what is actually we have to do in certain circumstances. So it comes with the experience. Yes, it is also sometimes supported by evidence, and sometimes the evidence is also conflicting, inconsistent. So every teacher of the country gives me this impression that we have to retain a very, very strong foundation of basic and classical teaching, and that has to be always built up with, again, the evidence that what is doable in our country, what are our solutions to our own challenges. And we have to be always thinking in this way that what is doable in our particular setting. So this was the basic concept of the E-Classic for Clinician, which we are dealing not only PPH, cesarean section, abnormal uterine bleeding, fetal medicine, whatever. So we are having a lot of workshops, and we look forward that every one of you sometimes join at some point of time. So it is a great pleasure to be with Gujarat Society, because whatever I am, what is the Gujarat has been the main pillar, their mentors, their teachers, to guide me, to share the vision, to help us out. And we have worked all together in our all conferences, all academic program. We have been together, Dr. Geeta and Dr. Deepak, and so many of you have been to Gorakhpur as well. And we had a beautiful memories about it. So it's a great pleasure to have Dr. Deepak Bhagre with us as a chief guest, who is a actually elder brother figure for so many people, including me, pan-India. He has been the past president of SOGOG and the past MD DGO with gold medal in 1981 from Ahmedabad. He has been the head department of Obs-Gynae, MP Shah Medical College, Jamnagar, scientific committee chairman, Gujarat State gynecologist. He has graced the position of President Jamnagar Gynae Society, President Jamnagar IMA, and member Board of Studies, Saurashtra University. First ever SOGOG audition 2014, and has delivered. Dr. Deepak is like an exemplary figure for our all young generation OB-GYN, who has a remarkable continued practice up to this time, and delivered about 62,000 babies in private practice since 1985. So it is something inspiring when our young OB-GYN are really irking away from the obstetrics, that how we can manage so well if we really have the very, very good protocols, and our system get ready for the every challenge which time present to us in present and future. So Dr. Deepak, it is really, really great to have you, and we request you to say your pulse of wisdom, which everybody is eager to listen from.
Dr. Sadhna, first of all, let me congratulate and thank you. Congratulate in the sense that you are standing for an excellent post, which you deserve it all the way. I've seen you working in Foxy since years. It's not a question of just 1, 2, 3, 4 years. But since I know you about, say, 15 years back, I've seen you in most of the managing committee meetings, most of the Foxy meetings, even the smallest things, and you've tried your best to see that everyone is getting help. That is your nature, to be a friendly person to all. So, Sadhna, from my heart, I really wish you, wish that you become our president in the year 2025. Apart from that, as a person also, whom I would say, yes, an excellent person, an excellent human being. So you deserve whatever you really wish for. Sadhna, there's part of that. Let me come to the subject also. PPH for an obstetrician is a nightmare, as everyone knows. But I'll tell you one thing. From my experience, we are always late in ordering blood, and we are always late in taking actions. See, basically what happens is by the time you think that she has lots of blood, she has lost so much of blood that only hysterectomy is an option left for you. And how many things you can try vaginally? So you got to really act fast. As soon as you feel this bleeding is more than something which you don't desire, you got to really think about it, at least order 2 BP. I'm sure everyone nowadays is keeping an IV line open during delivery. If they are not, please have an IV line with you. Don't deliver without an IV line. That is the first thing I will really ask everyone. Yes, I've delivered a lot before an IV line, but now I really realize that an open IV line, of course, not of 16, but at least even 18, 21, but you got to have an IV line open in case of emergency. The drugs will work, but they don't work. And the main thing is PPH comes into the patients whom you least expect. So like hydroneos, like twins, that you expect. So you're all prepared mentally and everyone. But 70% of the PPH will occur in the patients where you least expect it. And that's where morbidity and mortality starts. You got to really act fast, order for the blood components immediately as far as, even if you have to waste 2 units of blood, I wouldn't really mind, but act fast. That is the only message I would really like to give at this moment. Thank you again, Sadhna, for getting me into this. And I'm sure we are looking forward to the wonderful seminar now.
Thank you, Dr. Deepak. Very, very rightly says, because sometimes what you say, open IV line, and sometimes when we are having session with NGO and they say that, yes, no, like not every laboring woman need IV line. I am the one of the, like, what a pearl of wisdom that every woman, laboring woman who is delivering in institution must have a IV access, because there are so many unpredictable situations which we have to deal with. The rapid management and IV line is our lifeline. Thank you. What you have spoken, it is out of years of experience and years of facing the situation. Thank you, Dr. Deepak, and I'm really blessed to have your precious wishes, because that is invaluable and this is an asset for us to have such a good words and the emotions from you. Thank you very much, Dr. Deepak. We really look forward to have you in the whole evening. Dr. Vinit Mishra is not with us. We will just, he has sent his best wishes to us, and he is Director, Indian Kidney Research Institute, ITS Ahmedabad, and HOD Department of Obs-Gynae. He has been trained at various institutions at USA, published a lot of articles and research in field of stem cells, pelvic organ prolapse, SUI, and female sexual dysfunction. He has been my co-vice president Foxy 2016. So we had a long association, and he has sent all the wishes, and he always says that how the PPH related, coagulopathy related kidney injury comes regularly to his institution for the dialysis, and what Dr. Deepak says that how we should be proactive in management of the postpartum hemorrhage so that we don't have any renal shutdown. So Dr. Vinit always says that how his institution is getting. So thank you, Dr. Vinit, for this. And Dr. Geeten Sharma is our special guest. Dr. Geeten Sharma is like a person which we always look forward that he will be there for every gynecologist and obstetrician across India whenever there is any trouble related to medical legal issue. He is like a perfect mix of the medicine and the law, and there is so much to learn from his personality, his analytical nature, and his he observes like a surgeon and he observes like a lawyer. So Dr. Giten is practicing gynae Ahmedabad for 28 years and has done LLB with 15 gold medal top Gujarat University law. So he has surpassed all the law people over there, author of book Law in OB-GYN Practice, Consultant OB-GYN, Law a Doctor Must Know. These are the books which must be at the shelf of every obstetrician and gynecologist. Given more than 1,500 lectures, he has been always a sought after figure for all medical legal panels and all tricky situations. Vice President elect, he is the current Vice President of the FOXY from the West Zone, chairs Ethical and Medical Legal Committee. He has done a tremendous job. President Ahmedabad Obstetrician Society and hosted AICOG in 2017 and honorary Joint Secretary Sagog 2017-19. So Dr. Giten, it's a real great pleasure to have you. You are always traveling, so we feel it is like a reward that we have your presence. So we wish to listen from you, and especially the medical legal viewpoints also in the postpartum hemorrhage.
Okay, Sadhna, before Gitendra says, can I say some few words about Gitendra?
Yes.
Okay. Gitendra being a good friend, 15 gold medals, you can understand. I don't know where they kept them, but at least even if I steal them, they must be of a good value. Gitendra, I know he's also hosting. I just got into this because I would really like to say he's hosting the West Zone, the Foxy West Zone side in August 5-6-7?
4-5-6.
4-5-6. So that is going to be a part of medical legal jugglery and the obstetric gynec together. So whoever is listening to this person, I'm sure you'll all enjoy it. And with Gitendra Sharma being at the helm, we wish him also the best in his career in Foxy also. Thank you very much, Dr. Gitendra. Thanks, Santa, for getting me into this also.
Thank you. So, Dr. Giten.
Thank you very much, madam. At the outset, I will really like to thank Sadhna, madam, for giving me this opportunity to interact with you all. The things which have been told by Bhagde sir for Sadhna, madam, I endorse each and every word of that. So, I cannot explain the qualities of Dr. Sadhna, madam. She is so simple and she is a great leader, and I can say that she can be the best president of Foxy in future if elected. So regarding Dr. Bhagde sir, what I have no words to explain Bhagde sir. Again, the simplicity of Bhagde sir, we pay regards to Bhagde sir and Vinit Mishra sir through this, and very apt at this moment to say that we are organizing one conference, that is Vice President Conference of Foxy West Zone, that is on 4th, 5th and 6th August in Ahmedabad, and that is an amalgamation of obstetric gynec and medico legal. So one hall will be continuously for medico legal for 2 days, and one hall will continuously be for the obstetric and gynec. Regarding PPH, I always tell that every obstetrician very often come across the patient of PPH. And whenever we come across the patient of PPH, see, in law it is said that complication per se is not a negligence. So it can happen, PPH can happen because it is an unpredictable complication. It can happen to anybody in any patient. But the problem is that we don't document it properly. So although we treat the patient perfectly, but when we go through the documentation on the part of an obstetrician is very poor. And that is the only reason why we lose the case in the court of law. See, we have done one analysis, and out of 100 cases filed against obstetrician, 50 are of PPH only. And the 95% of the cases which are decided against obstetrician in the court of law, the reason is poor documentation, and rest 5% is due to poor representation in the court by the advocate. So dear friends, if you want to save your skin, make a habit to make good documentation. And during the conference at Ahmedabad, we are going to come out with uniform documents, and we will provide the documents, uniform document to all the delegates and all the FOXI members in that conference, so that you can save yourself in the court of law by taking help of that document. So I wish once again all the best to Sadhna Madam for her election, and I pay my regards to President Secretaries of all the societies of Gujarat and Jammu and Kashmir and Gorakhpur who are involved today in this webinar. So once again, thank you. Thank you very much for giving me this opportunity to be guest of honor for this webinar. Dr. Sadhna Madam, thank you.
Thank you, Dr. Gitin. As always, you are always to the point, and this is that if we are not documenting everything, and which is so natural in case of PPH, what Dr. Gitin says, so many cases, legal, medical, legal, many related to postpartum hemorrhage, because it is so sudden, so rapid, that we really tend to forget two things, that is a communication and documentation, while we are like doing our best to save the mother from the criticality. And this is that's why the ready-made consent and these things which actually sensitize that every laboring woman or every patient can be a potential medical legal issue, and it should be like in our clinical practice that putting two-line and giving crystalloid. It should also be in our hard code that how to take consent and what is the language, what we communicate to this. So thank you very much, Dr. Gitin, for your precious presence, and thank you, Dr. Deepak, for your, and we really wish that you stay with us to the whole evening. And now request Dr. Yes, because we wanted you to as an expert in the panel as well.
I know. No, let me finish some of my opinions and I'll try to join again.
Yes, sir. Thank you, sir, for that. And Dr. Babita, you can go with the session.
Heartiest thanks to Dr. Deepak Bagre and Dr. Geetendra Sharma for their pearls of wisdom. Now, quickly moving forward towards our scientific session. Our first talk would be by Dr. Sadhna Gupta ma'am on the topic being resuscitation and medical management in PPH. I would like to invite our esteemed chair session, Dr. Amita Shah. Madam is currently practicing at a private hospital in Baroda since past 30 years. She has worked as secretary in Baroda Obs and Gynae Society and also as vice president. And currently she is the president of Baroda Obs and Gynae Society. Her special areas of interest being adolescent health, menopause, and infertility. A very warm welcome to you, ma'am. Then we have Dr. Paresh Palmer. Sir is practicing gynecologist at Pratham Hospital, and his areas of interest being laparoscopy and infertility. Currently, he is secretary of Nadiad Obs and Gynae Society. And a third chairperson being Dr. Brijesh Patel. Sir is secretary of Valsad Obs and Gynae Society and consultant gynecologist and laparoscopy surgeon at Parthi Hospital, Valsad. A very warm welcome to all our chairpersons, and I would request Dr. Brijesh Patel to introduce Dr. Sadhna Gupta and all the chairpersons to conduct this session. Dr. Brijesh, are you there? Okay, I request Dr. Paresh Palmer. Sir, kindly introduce Sadhna, ma'am. Dr. Paresh.
Doesn't matter. I'll do that.
Dr. Amita.
Yes, I'm over here.
Kindly do the honors, ma'am.
Yes. It's my great pleasure to introduce our esteemed speaker, Dr. Sadhna Gupta ma'am, who is a multifaceted personality, has done lots of work at the FOXI level, national level, local level. and she is such a good academician, yet so simple person. I have a privilege to introduce her for today's topic, and she has done. She has her list of her academic session for this. Is the vice president mainly of the Foxy of 2016, and so many other things. Most important thing that she is contesting for the Foxy president electionship, and I wish Madam all the best for this contest. And I invite her for the today's lecture. That is her topic is resuscitation and medical management in PPH.
Thank you, madam. Thank you for the kind introduction and your precious wishes, which is so invaluable for us. So I will be dealing with the first step in the postpartum hemorrhage, and we will say even before the first step, because our PPH management actually in day-to-day antenatal care and in our day-to-day practice, because it is much before when the woman comes to us in the labor room for the delivery or the cesarean section. So this is my presentation full screen? Yes. So I will be dealing with the medical and the first line management of the postpartum hemorrhage, and these are the wonderful memories which we always have, and these are the Gujarat what is we have with the Statue of Unity at the Kevadia, and it is always what I say that what I am today, the guidance and the association with the mentors, teachers, and the leaders and the friends have a great way. So I bring greetings from the land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. And in managing PPH, this inner peace is so very important so that we can be coordinated, cool, and composed. Why we are taking PPH E-Classic skill and drill workshop? Because it is contributing to around 35 to 40% of maternal death globally as well as in our country. And this is a conscious picking issue that Africa and Asia is constituting major proportion of maternal death, and it still remains our top priority. But what is the clinician perspective that if we are dealing with any sort of obstetrical practice, we are bound to get into 2 to 10% of deliveries, and out of which 1 by 1,000 can be massive and life-threatening. Complication can be severe, like hysterectomy, ICU admission, massive blood transfusion, which are in category of near miss, and it is a lifetime scar for obstetrician and our team as well. So India, we are contributing to PPH is contributing to 35 to 56% of maternal death, and it is the thing which we have to be always well versed. What is important that the PPH tests the functioning of health system and skill of health worker. PPH management tests your skill, your guts, your leadership, and what day to day you are investing in your system, training your paramedicals, keeping the check on the what is available in our all train, because we are bound to get in unpredictability, what Dr. Deepak Bhagde said, and we can lose the patient after postpartum hemorrhage in a very, very short span. In India, why we are supposed to be a very good clinician all over the world and sought after doctor, because we are dealing with a heterogeneous complex population. So we have all the issue that anemia, there can be delay, there can be the like a inadequate obstetrical care, but we have all the new challenges, and Gujarat being one of the very, very important state where the IVF and the high technologic medicine is working. We have all pregnancy with myoma, obesities, medical comorbidities, as well as the coagulopathy. So as an obstetrician and gynecologist of India, we have to be ready with everything. Maybe in Africa and Latin America, we are not having the new issues, but in our country, we have to be ready with facing the challenges. And what is the aim of our, these workshops, that we make a clear roadmap in our mind, because when we save the patient with PPH, it enhances our confidence and esteem. But if we lose it, it can be a very, very long demoralizing effect on obstetrician and the team. So what Dr. Deepak was saying actually, that the IV lines are not good. We are diagnosing late postpartum hemorrhage, and the implication of suboptimal management can be numerous. It can threaten well-being of mother, neonate, family, obstetrician, and with what Dr. Giten says, that it has a very, very important medical, legal, media, and sometimes the social issue, and we have to be ready with the alert. This is the time when we have, like Mr. Modi, Honorable Mr. Modi, right from Gujarat. So we this time, currently, we have a great political will for the maternal and child health and the health overall. But as a healthcare person, we have to be very sure that any patient who comes to us as a secondary or tertiary facility, we have a good protocol like a blue code or things in order so that we don't lose the time in PPH management. Now, prevention of postpartum hemorrhage, and what we say right before medical resuscitation, there is a thing which we can do much before that. So prevention of postpartum hemorrhage, first thing is the risk assessment in our day-to-day OPD practice. We as an obstetrician and gynecologist know so many things, but we have to ask so many things so the people don't give the history of the previous history of postpartum hemorrhage. So we have to be very, very meticulous for risk assessment ongoing in every antenatal visit, and especially the few issue history of PPH, low-lying placenta, presence of preeclampsia, thrombocytopenia, and the treatment with anticoagulant, which sometimes get missed in our day-to-day practice, which we are not that careful, and sometimes we don't take the suggestive history. But what next? We have to turn knowledge into action. So we have identified risk factor, but the patient can go anywhere at the time of emergency. So identify risk factor, flash at antenatal card, counsel family for the PPH risk and the need for having delivery at the equipped center, as well as maybe the need of blood transfusion, and sensitize all labor room staff that look for the antenatal card. If this line is flashed in the red color, you have to be proactive with all prophylactic management protocols as well as the armamentarium. So active management of third stage of labor have gone a sea change, and now the oxytocin agent administration within 1 minute of birth of the baby is the most important component. So every woman, it is like a vaccination against postpartum hemorrhage, and every woman who is delivering anywhere must have the active management of third stage of labor, because it short in third stage, reduce risk of PPH, reduce severe PPH, decreased need of blood transfusion, and decreased risk of anemia. And now with the delayed cord clamping, it also have the advantage for the baby. So I have actually, like in my long journey of Foxy, active management of third stage of the labor and keeping oxytocin in the fridge, I have been the very, very important part of it with the Path Oxytocin Initiative and Helping Mother Survive program with Dr. Hema Divakar. And that time we came to know that even in a one institution, that different units are having different protocol. And now it is a standardized, and it is very happy to know that now the things are streamlined and we have the uniform protocol in many, like we can say around 80 to 90% of the institution. So it is a 10 unit, either IM or IV, because oxytocin is the thing which any nurse and any junior doctor can give, because there is no contraindication of oxytocin use and it has no effect on the maternal vitals. Misoprostol has gone a turbulent journey. Still, it is a second choice of drug of choice for the active management of third stage of labor when the oxytocin is not available, and it also has to be kept in sensitive to moisture, so away from the humidity. So all professional body says that active management of third stage of labor and oxytocin to be used. Now 1.5 years have gone, and now we have the carbitocin, which is a long-acting oxytocin, and we have the room-stable carbitocin as well. So this is a drug which our women and we have waited a lot, because it is a long-acting, very, very strong affinity to oxytocin receptor, and it reduces the need of further oxytocin infusion in our practice. Champion trial, India was a great contributor to the Champion trial, and Now it is recommended that the single dose of 100 microgram in 1 ml to be administered in 1 minute after cesarean or vaginal delivery is a very, very good method of active management of third stage of labor. And it supersedes, it is superior to oxytocin because it eliminates requirement for infusion after initial days, dose, and it is a long acting. Important thing is that yes, we have a very good drug which is room stable, and I wish to also communicate that carbitocin, which we call room stable, that is also to be at 2 to 30 degrees. So nowadays, when May, June, it is a 39, 40 degree temperature, still it is better that we keep carbitocin in the refrigerator for the better efficacy. Important thing is that all drugs should be available, and every skilled birth attendant must be aware that what are the components and when and how carbitocin or oxytocin is to be given. And as a leader, we must be doing all audit that our 100% of women receive active management of third stage of the labor. So this is about the prevention with a good, very, very important risk assessment and the active management. But the PPH remains unpredictable, and we have to, what we say, the more you sweat in peace, the less you bled in war. And we have to be ready with our fire drill in our heart. This we have to have the steps that what we too should do when we get the call for the PPH management. Why do we lose mother? Because we are having delayed or less correction of hypovolemia and the cause analysis and control of bleeding. So it is the time and it is the amount. So what is the golden hour? In first 2 hours after delivery, if the patient of PPH gets the good and aggressive treatment, we can save most of the patient. And this should be the policy of all obstetrician and gynecologists, be it a small nursing home, be it a public health institution or corporate, that don't ship the patient before 2 hours and in that golden after delivery. And that 2 hours you have to look, every nurse should look bleeding PV, tone and height of uterus, vitals, alertness level, and the oxygen saturation. So a little bit about the primary and secondary PPH, everybody knows it, and it is 500 what we say, but any blood loss which can make the patient hemodynamically unstable is PPH. So when you are called, what you do? First, you make a quick 360-degree view of whole situation, quick review of antenatal, quick review of what was the incidence during labor duration, how was the delivery, and while we are resuscitating and starting initial management, cause analysis is a very, very important prerogative of the leader. We have the classical teaching, tone, tissue, trauma, thrombin. We all know. Important thing is that we have a quick analysis of the labor record as well as the antenatal record, so that we know if it was a chorioamnitis, use of tocolytic drug, use of nifedipine, max help, it is more likely to atony if there is any fibroid or multifetal pregnancy or the IUFD or the preeclampsia, then coagulopathy can be the cause. So important thing is that we know the cause, we can enumerate, but important thing is the cause analysis, which is very important and which have to be very, very smart and the methodical. Of course, that atony cause contributing to 70% of PPH. When the placental delivery is difficult or not retained, that it is a retained product. And important thing is that we can have more than 1, 2, or 3 cause for the PPH, like if it is a prompt, sepsis lead to atony, use of tocolytic used to atony, and the use of ecosprin or the heparin can cause the coagulation disorder also. So always think there can be one or the more than one cause for the PPH in that particular cause. Now, why we tend to miss what Dr. Deepak rightly says, that we actually lose the time because this can be deceptive. The nature has been kind enough to make the pregnant woman hypervolemic, so she can withstand the initial amount of blood loss. So there may be no any change in the blood pressure. Yes, the first change in the heart rate, and we have to be careful about it. And that's why there are pits and fall in the diagnosis of the PPH. Besides, visible estimation can be under or it can be over. In PPH, we can say the overestimation is safer because it gives you time and a little bit management is not going to harm. PPH can be concealed also. It is not always the revealed PPH. There can be broad ligament hematoma. There can be uterine injury. And what is our clinical protocol says, and what our Manyata program says, that give clear instruction to labor room staff. It is 5 soaked napkin, 1 soaked big napkin, continuous trickling of blood, or you are quantifying or the altered woman condition, like she is having nausea, she is anxious, she has vomited twice. We make sure that the patient is not having PPH, and it is time that our senior obstetrician and gynecologist is called. So it is a blue code and whom to call. So this is so very important that it is not like somebody say, call him. We have to be always ready, and every staff should be knowing whom to call. Your friend anesthetist, senior nurse, our obstetrician colleague, smartest ward boy as a die, and the blood bank person and OT person, that OT should be ready if there is any need of the surgical intervention. So the degree of quantification of PPH is very, very important, because that sets the stage, and it is high pulse. Blood pressure can be normal till the patient has actually lost around 15 to 20% of blood, urine output, capillary refill. So these are not rocket science. These are the simple things which we can do. Important thing is that we have to have a very, very quick analysis that what amount of blood patient has lost. Shock index is a very, very simple thing. That is a heart rate divided by systolic blood pressure. And if it is less than 1, you have a breathing space. But if it is more than 1, you have to be very, very aggressive. And a classical rule of 30, which we all know, and we have to implement in the quantification of the blood loss in the PPH. We have to be 24/7 ready for all drugs, oxygen, airway, emergency trays for PPH, chart for PPH, so the our nurses are not confused, and all contact number of the person whom we wish to call. So basic EMOC is the replacing fluid, send blood group for the cross matching, catheterization, give antibiotic, record event and communicate. So these are the basic things which every patient with PPH must be having. And when there is a massive or the moderate loss, we have to be ready with the full protocol for the resuscitation. One important thing is what we listen and learn from the teachers, that some nurse or the resident have called senior person. Yes, this patient is having PPH, and patient was okay. So they said that, why you called me? Never say this, because next time when she is having the PPH, she will be frightened to call to you. So when there is a moderate to massive PPH, assess airway, breathing, circulation, give oxygen irrespective of the maternal oxygen concentration. And what Dr. Deepak says, it must be the IV cannula. And when you anticipate or diagnose PPH, it should be 2 IV cannula, green or the gray. Keep the patient flat, keep the patient warm. This is very important. Catheterize and assess need for the blood transfusion by the quick analysis of HemeQ and the indices of shock. So we should not be proactive in ordering blood transfusion. If hemoglobin is around 7.6, there are indices of shock which is telling the high level of shock. We have to order for the blood component. Manual aortic compression, we must have this art, especially in placenta agnita spectrum. Sometimes there is sudden so much amount of blood is lost in a few minutes, and we have to be knowing that we have to stand on the stool on the right side. We have to have a straight elbow and give that much of pressure that the femoral pulse is not palpable. So these are the few things which everyone must have the skill and to do whenever it is needed. And we always have to be very, very good communication and the record keeping. When you are putting the second IV cannula, at the same time, send the blood for cross-matching, send the blood for the renal function, liver function, hematocrit, as well as the coagulation profile. So we, in our PPH box, it is not that there are the drugs, there are the few equipment there are, but there must be the blood transfusion requisite form, good number of plain vials citrated, and the EDTA vial. So PPH bundle care, WHO have come with us, and as a FOXI presidential candidate, this is my vision, that we all over the country, we advocate that every obstetrician follow these PPH care bundle and the maternal care bundle for improving our maternal and the neonatal health statistics. These are the component: uterotonic drug, crystalloid, tranexamic acid, uterine massage, and then the second level measure. So start for help, airway, IV cannula, crystalloid, and the important point about crystalloid, that always infuse either ringer lactate or normal saline. Never and never start with the Hemaxil, which sometimes anesthetist says, because crystalloid remain in the intravascular space, they does not cause pulmonary edema, and the colloid infusion can cause pulmonary edema as well as interact with the coagulation profile. Ringer lactate, normal saline, and if you think that it must be the 2.5 to 3 times, so if you are estimating the patient has lost 700 ml, you should give that around 2 liters of the fluid into the first 3 hours. Then ask the right question: placenta has been delivered. Did bleeding start immediately after delivery of baby? More chances that the patient is having traumatic PPH. If placenta is not delivered, mobilize team for MRP, and if it is not complete, explore genital tract. However, if there is a suspicion of past disorder, that is placenta accreta spectrum, never and never attempt to remove the placental parts. So you must be very, very careful about it, like low-lying placenta or any history of the DNC, you can do the right then and there ultrasound. So make that sure that you are not dealing with the accreta spectrum. These are the few obstetrical skills which we have to retain with the wonderful teachers, that how to give the fundal massage, it should not be vigorous, how to remove the blood clot from the vagina, and always identify fundus of uterus, because the inversion mild to major can be the cause of the PPH in the patient, and especially in obese patient, sometimes we are not able to assess the tone and height of the uterus. What are the medical drugs? Oxytocin, carbetocin, methyl ergometrin, bisoprostol, prostaglandin, F2-alpha. So we are fortunate enough to have a good number of drugs. Important thing that we must exclude contraindication, and the second thing, we must have the optimum use of every drug. So you can give oxytocin up to 80 to 100 units, methyl ergometrin up to 4 or 5 doses, PGF2-alpha up to 2 milligram. And that is very important, that you give only one injection and see, no, it is not responding, so let's take the patient for the surgery. Optimum use of the drug in adequate dose is very, very important, and we have to always exclude contraindication, like never give prostaglandin F2-alpha with the asthma patient and methyl ergometrin in the anemia or the pre-eclampsia. If the one drug is not effective, then the second or third drug will be effective. So always, if one drug is not effective, never afraid to use the second and the third line drug, and always IV fluid resuscitation. Again, I emphasize, if we are not aggressive in IV fluid resuscitation, the uterotonic is not going to reach up to the uterus. So this is very, very important, and the right use and the right availability of the drug. However, if you have given 3 doses of PGF2-alpha or 3 doses of methyl ergometrin, this is the time to think for the second level measures. Tranexamic acid, women trial, it has been the first trial have been published when I was attending the FIGO, that is the 2015, and now all professional bodies says that the tranexamic acid within 3 hours of the birth should be given. All studies and the WHO recommend, it says. One important thing I will say, this is the paper from the anesthetic, that is from the European Association, that inadvertently tranexamic acid has been given as a regional anesthesia because the ampule of the tranexamic acid resemble bupivacaine. And in our National Medical Council, there are few cases like that, and we have to have a magnifying glass in our OT and labor room so that no human error happens. And as a professional body, we should also guide our pharma industry that we have to have a different sort of the ampule making, so that in case the human error does not add to our woes. When to use blood transfusion? Whenever there is a moderate to severe PPH and hemoglobin less than 7 grams, and ongoing bleeding, or there is a risk for the coagulopathy. We can have a coagulopathy, especially fall in fibrinogen level. So all DIC definition says we must have a precedent obstetrical situation which can cause DIC. And these are the fetal death, HELP, severe preeclampsia, amniotic fluid embolism, abrupt shock. And if there has been the precedent obstetrical situation, we should be very, very careful about the fibrinogen level. And we have to retain again the art of bedside test, because whatever we do, it takes half hour to 1 hour to get the coagulation profile result. But you can do then and there the bedside coagulation test by simple taking the blood in the test tube, seeing that the blood clot is formed and the blood clot is solid or not. So this is very important. Massive transfusion protocol, what Dr. Deepak was saying, we are overburdened with the knowledge. So everybody listens that the blood transfusion, it is 1:1:1. I just wish to communicate that after 2 or 3 or 4 units of PRBC you have given, after that, there is a situation that we can have the dilutional coagulopathy, and then the fresh frozen plasma is needed. However, when there is a situation like the DIC or the low fibrinogen level, then we need the fresh frozen plasma from the very beginning. What we want to achieve, right, hemoglobin 8, platelet count 75, prothrombin time less than 1.5, and we have to have a good systematic arterial pressure. Always be ready with the all trays and all the thing, and what we are having, the always record event, vital parameter, what fluid has been given, and the communication which has been recorded. Manyata, I have been the part and parcel of Manyata project since around it is 10 years, and we are reaching to very, very small places. Paramedical, you can see the places, very, very remote area from Chhattisgarh, from the Bihar, from the UP, and the Rajasthan as well. So we are actually giving that confidence to the paramedical, and Dr. Babita has been with us as a trainer, and how different it actually makes at the ground root level. Always treat the cause, atony with the oxytocin, retained placenta with MRP. In person, we will going to have the case and the laceration. So a bimanual uterine compression, these are the few art which we have to retain in the teaching. This is not the time SR cannula we are going to have. And very, very important that when to shift the patient to OT. Right exploration at right time with the right technique. A wonderful innovative by our own Dr. V.P. Pelly, that is the transvaginal uterine artery clamp and the aortic clamp. And we have to be very proud of our own Dr. Nalini Mishra with the Chhattisgarh balloon and the new innovation in the balloon tip balloon. Always mobilize for the manual removal of the placenta when there is a retained placenta, because the real difficult part about MRP is the decision to undertake it. And we have not to delay the decision and have to mobilize accordingly. Coagulopathy, I will say the thrombocytopenia, ITP, drug-induced is so common, and always it is very, very important that in our public institution, it is not hemoglobin, but it is a total blood count, which happens so that we have always a watch on the platelet count. When it is time to open up into the PPH, this is an important question. Uterus flabby, she is pouring blood. You are not able to such a high cervical tear, indefinite contour of uterus, you are feeling lump. This is the time to open up. And if patient low, always use bimanual aortic compression, NASD, because it gives you breathing space for you, for your anesthetist. Always we are there to learn the skills. So final takeaway, we have to save lives. Every woman, everywhere, this is very, very important. We have to cross the regional bias in our maternal and neonatal health statistics gap that is we have. Drastic situation need aggressive measure, set protocol, take good decision, prepare team of friends, and have a sharp eye on potential medical legal issue. Keep good communication even in worst of circumstances. So if you can fill the unforgiving minute with 60 seconds worth of distance, run, run, run. So this is PPH, and with this, I seek everybody's blessings, good wishes, vote and support. Thank you very much for nomination in a big number for my Foxy presidential candidature. Together, we have a lot of things to learn. Gujarat have a lot of things to do to our country in many, many ways. Chiranjeevi Yojana, and we have a very, very positive Prime Minister from Gujarat who have actually set the tone of our country at a different level, and we really look forward to working with you under your guidance, sharing your vision and the experience. Thank you very much.
So,
I would request the chairperson to give their inputs on this topic. Dr. Brijesh. Dr. Brijesh Patel, are you there? I can see his name. But
I think,
Dr.
Babita,
Brijesh
can I
Patel.
comment something on that?
Yes. You can.
Sadhana ma'am, as a teacher means I feel like I'm a student for life for you. Always an excellent deliberation with such a crisp message. I think we all are benefited so much. Thank you for sharing your immense knowledge and short listed we are getting every day basis also, but this was too good, ma'am, for the practical tips. I hope Babita chairpersons can take over from here.
Yes.
It's always a pleasure to meet you, ma'am.
Thank you, Archana.
Doctor, you would like inputs of Dr. Amita Shah?
Yeah,
Yes.
Amita ma'am is here. She's here.
Yes.
Sadhana madam has
name of
given
Dr.
a very
Brijesh,
good,
so, but I don't
very
know why.
Hello, good evening, madam.
hello.
Sorry, I was in middle of the procedure. So,
Okay, Dr. Brijesh, yes, give your inputs.
by the way, it was a nice lecture and very informative.
Okay.
Shilpi Rawalilla.
Dr. Amita,
please.
please
Dr.
continue.
Amita, yes, please.
Yes.
Yes,
Sorry. Are you able to hear me?
Yes, ma'am.
Yes. It was a very comprehensive and very complete talk by Sadhana madam. Unfortunately, I have lost the connection, but still, if you are able to hear me, it's fine. It was a complete talk, right from how to recognize, what to do, the basic things, and the manyata, this thing, and all that heterotonic, very nicely described. And we all should follow this, and we can certainly reduce the maternal mortality, ma'am. Very good presentation and very crisp message, ma'am.
Thank you, madam. Thank you, Dr. Amita. Thank you, Dr. Archana. Thank you, Dr. Brajesh.
Thank you very
Thank you
much.
so much, ma'am, for your wise inputs. And thank you, speaker and chairpersons. The first session went really well. Now, in our second session, we have Dr. Samarth Ram.
Yes.
Sir will be doing a video demonstration of SR cannula. And our chairpersons for this session, Dr. Khyati Daru. She is an infertility specialist, Silvassa, and president of WAPI, Obs and Gynae Society. A very warm welcome to you. Then we have Dr. Shilpi Rawal. She is secretary of Nadiad, Obs and Gynae Society. She is a full-time gynecologist at Methodist Hospital, Nadiad, for 3 years, practicing as full-time gynecologist since last 25 years at her own Surbi nursing home. Her special areas of interest being preconceptional and antenatal care, menopausal care and counseling, and special interest in overall health and emotional well-being of women of all age groups by means of providing awareness and education regarding nutrition, exercises, meditation, and medicine. That's a really commendable job. A very warm welcome to our chairpersons. Kindly invite and introduce our speaker. Dr. Khyati, are you there? Kindly introduce her.
See there, at all?
Yes, she's there.
Yeah. Am I audible?
Yes, you're audible. Dr. Khyati, you're audible.
Ma'am, your voice is breaking, ma'am.
Yeah, there is poor network, I think.
Yeah. Shilpi ma'am has
Dr. Khyati?
Sir. Sorry, Khyati ma'am, your voice is breaking. Okay.
So let me introduce her. Dr. Khyati can give her inputs later on.
So,
Please with us. Dr. Shilpi is our secretary. Dr. Shilpi is
Yes, I am here, ma'am.
Okay, Dr. Shilpi, kindly introduce her.
Sure.
maybe. Now, is it okay now?
Good evening, sir.
Am I audible?
A warm welcome
Yes,
to this.
yes, I'm here. Can you hear me?
Hello.
Can you hear me?
Yes, you are audible.
Yes, yes. He's the director and HOD of Obstetrics and Gynecology, Sandhayaram Hospital, Palakkad, Kerala. He is the winner of prestigious senior category Foxy Korean Award, 3 times winner of Dr. C.S. Dawn Prize, Foxy Figo Award, KFOG President Gold Medal, and UA Foxy Award. His PPH suction cannula and oral hydration therapy to prevent severe PE could bring down MMR very significantly in Kerala, Tamil Nadu, and Andhra Pradesh. His publications are published 26 original papers in national and international journals and has special interest in postpartum hemorrhage, preeclampsia, and amniotic fluid, optical density, guided induction of labor. Welcome, sir. We are blessed to have you with us.
Yes.
Thank you, sir. Come.
Thank you. Do it. I think I'm audible, no?
Yes, yes.
Yes, sir.
Good evening, chairpersons, and good evening, everybody. I am very much thankful to my chairperson, Dr. Shilpi Rawal, giving me a nice introduction, and very much thankful to Dr. Sadhana Gupta ji for giving me this opportunity. And I am there with this program, multiple number of webinars I'm having. In fact, I visited entire India in multiple sessions. The title of the topic I'm presenting, SRPPH suction cannula for the management of atonic postpartum hemorrhage. I think I'm audible, right?
Yes, sir.
Okay. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. Around 50% of the mothers died due to atonic postpartum hemorrhage. Millennium Development Goal 5 aims for reducing maternal mortality to 70 per 1 lakh births by the year 2030. In South India, all 4-5 states already achieved these figures now itself. When conservative methods like uterine massage, uterotonic drugs, and balloon tamponade fail, surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Many times, mothers die on roads while being transported to higher medical centers. This is the SRPPH suction cannula which I have developed, measures 23 centimeters long. This is the fundal portion is having round larger holes, cervical portion is having smaller holes, and is the vaginal portion not having any holes. This is the nipple of the cannula which stay outside and to be connected to the suction machine through tubing. Coming to the mechanism, how it works, this is the atonic flabby uterus bleeding, cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, and firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction. Here I'm showing the uterus here, contracted, retracted. Inside the uterus, the cannula is working and creating a continuous negative pressure. It is a global, powerful negative pressure creating global constriction of the uterus. You can see it is not small rugosities. You can see the coarse ridges on the entire surface of the uterus, both on the upper segment and lower segment. For the same reason, cannula, SR cannula is very effective to stop bleeding, even in case of lower segment bleeding. If somebody says cannula is not working for lower segment bleeding, is not correct. You can ignore it. Achieving closed uterine cavity is a basic and fundamental requirement for the functioning of suction tamponade system. Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. It's not possible to achieve closed uterine cavity with a single design cannula. This is a post-abortal uterus. The uterocervical length is small and the cervix admits only one finger. This thin cannula is sufficient for this and it can achieve a closed uterine cavity. This is a postpartum uterus, immediate postpartum. If you this is the bigger diameter cannula, we need to stop bleeding. create negative pressure inside uterine cavity. If you use this thin cannula for a postpartum uterus, this is a 8 to 10 centimeter dilated cervix, and if thin cannula inserted, this cervix cannot grip this cannula firmly, and it is not possible to achieve a closed uterine cavity, and it will not be effective to stop bleeding. 5 different sizes of cannulas are made to match different cervical dilatations and to match different uterocervical lengths. These are the cannulas designed for atonic PPH after vaginal delivery. This is lateral view, and this is anterior posterior view. And these are the cannulas designed for atonic PPH during cesarean section. These are the shorter size cannulas. Thin cannula is meant for cervixing, admitting one finger. The larger diameter cannula is for dilated cervix. And this is another cannula specially designed for bleeding after MTP or vesicular molar extraction. And this cannula is can also be used as a suction tube introducer while doing cesarean section. In balloon tamponade, when we compare balloon tamponade with SR cannula, in balloon tamponade, the mechanism is totally opposite. Here, the water-filled balloon dilates the uterine cavity, and the distended balloon compresses the bleeding sinusoids to stop bleeding. Whereas the vacuum tamponade system assists the natural physiological process of contraction and retraction to stop atonic bleeding. I would like to show a small video showing the management of atonic postpartum hemorrhage with SR cannula.
Woman bleeding profusely. Vagina retracted with white blood speckles like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be filled bimanually. Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. You can see complete cessation of bleeding within 4 minutes. Retracted well.
Application of negative pressure. A negative pressure of 650 millimeters mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be applied by just switching on the machine. Then how long to keep the cannula inside the uterus? This is the commonest question everybody asks. Usually the cannula can be removed after 6 to 8 hours. In case of high-risk women, cannula can be kept inside uterus as long as the bleeding expected, even up to 24 hours. Whenever there is a recurrence of bleeding, we can switch on the machine. The question is how long to keep the cannula inside, how long to apply measure is all at the discretion of the obstetrician. If the woman starts bleeding, you can just apply negative pressure. And how long to keep the cannula is also your perception. If you feel that the woman may not bleed, you can remove the cannula. If you feel that the woman may bleed for longer times, you can keep the cannula inside the uterus for longer periods. SR cannula application for atonic PPH during cesarean section.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with the thin, long cannula. As this is an elective section, I am dilating this cervix with index finger. I use thin, long cannula, which I call it as a number 5 cannula, as a suction tube introducer. Suction tube should be connected to the suction machine. Cannula should be kept in proper position like this. Cut edges should be kept close together. Mop pressure applied. Negative pressure applied. You can see complete cessation of bleeding. Contracted and well retracted uterus. You can see practically no bleeding. I'm closing the left angle under direct vision. Contracted and retracted uterus. Blood loss less than 100 ml.
For application of negative pressure, it is not mandatory that you should close the uterus. You can just keep the cut edges together and then apply negative pressure. If there's air leak, you can apply a cotton pack on the wound and press there. Because of negative pressure, the cut edges come close together, and on itself it forms a closed uterine cavity. And if we leave 1 minute time, the entire blood in uterus go back into the circulation. Uterus becomes a cricket ball like feeling. And prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH, like PIH, anemia complicating pregnancy, and accidental hemorrhage, and so on.
Prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blade speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, left 2 fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers, tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml.
SR cannula for traumatic PPH. I suggest to apply SR cannula for every case of PPH, whether it is traumatic or atonic. In case of advanced traumatic PPH, some amount of uterine atony is always possible. Cannula corrects this atonic component and reduces bleeding. When negative pressure applied, the cervical tissues get compressed firmly on the surface of the cannula and stops blood flow in descending cervical vessels. This results in decreased bleeding from the cervical tears or upper vaginal tails. When you apply traction on the suction tube gently, the entire uterus en masse descends down. There's no need to apply sponge holders to catch hold of the cervix. You can apply a speculum and a good source of light. You can close the cervical wounds or vaginal wounds in a bloodless field. SR cannula is very effective for transporting the woman with PPH to higher medical centers. Here we use this manual suction pump.
Manual suction pump can also be used to create negative pressure inside uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula.
This manual pump is very effective. It can create same 650 millimeters mercury of negative pressure. It is very useful when there is no power and during transport. How to remove cannula after the procedure. After the completion of the procedure, the cannula cannot be removed easily as soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Cannula can be removed.
Easily removed after gentle separation of these adhesions with finger manipulation like this.
This cesarean we did last night. Next morning we are removing this cannula. We have to insert fingers. We have to insert fingers between the cervix and the cannula and go on sweeping around the cannula, detaching the stuck tissues into the holes of the cannula. Once tissues are detached from the holes, the cannula come out easily like this. How to clean the cannula? This is one of the common question people ask me.
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Then the question is whether SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but inversion of uterus can be treated with SR cannula. You have to reposition the uterus back into the abdomen. You have to insert the cannula into the uterine cavity and apply negative pressure. The uterus get freezed, and it will not, the reverse inversion of uterus do not recur. Cannula is also very effective to stop uterine bleeding, even in case of coagulation failure. In a case of cuvular uterus with coagulation failure, and we have inserted cannula and created negative pressure, we could save the mother and save her fertility function. Further, if there's any difficulty, you may call to my number. I have given my number on this cannula itself. You can call me. I'll come to your help. Under care of Government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe preeclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh. This oral hydration therapy to prevent preeclampsia is again my own original work. Hands-on training workshop was conducted at District Hospital Chittoor. Suction cannulas were provided to all institutions conducting deliveries like PHC, CHC, area hospitals, and medical colleges. ANMs and ASHA workers were assigned the job of OHT to all antenatal mothers to prevent severe preeclampsia. Oral hydration therapy is nothing but making every antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. In peripheral centers with suboptimal facilities, I advise the prophylactic application of SR cannula to all women, both in case of vaginal deliveries and cesarean sections. I would like to present the 3 months review of the results of SR cannula in the entire Chittoor district. 8,396 deliveries occurred in 3 months period. 1,500 applications of SR cannula has taken place, and you can see around 1,000 applications took place, vaginal applications. If you see the blood loss here, blood transfusions here, for 8,300 deliveries, only 28 units of blood was given. There's no PPH maternal death during this 3 months period, and the report of the doctors was excellent. Control is good, saved 2 patients with PPH, minimal blood. You can see all the doctors from all centers, they have given their report, which is very excellent. 5 years performance of OHT and SR cannula in entire Chittoor district. Recently, I got this report. You can see here in 2017-18, 47 maternal deaths occurred, whereas 22-23, only 9 deaths occurred. Hemorrhagic deaths were 9 deaths in 17-18, whereas 0 deaths in the 22-23. In the sense, for 30,000 deliveries, not a single maternal death occurred due to PPH. And if you see the maternal mortality, MMR, 83 MMR during 17-18 dropped to 33.3 in 22-23. One important observation I would like you to observe here is regarding OHT, 17-18, 16 maternal deaths were there due to PIH. This year, the maternal deaths was only 1 due to PIH. So we can comfortably say that oral hydration therapy can prevent maternal deaths due to pregnancy, hypertensive disorders of pregnancy. The significant reduction in MMR is due to the combined effect of SR cannula and OHT. Now, entire Tamil Nadu, Kerala, over 80% of Andhra Pradesh and many major hospitals in Karnataka are using this SR cannula to prevent and treat PPH. Kerala Federation had included this device in its obstetric protocols to prevent and treat PPH. You can see the MMR of Government of India report. There are drastic reduction of MMR in all 4 South Indian states. All these 4 states are using SR cannula. There is 22% reduction in MMR in Andhra Pradesh and 36% reduction in Kerala. So the last year MMR was 19 in 19 in Kerala, which was never before. SRPP suction cannula is a breakthrough innovation to prevent and treat atonic PPH. There's a paradigm shift in the management of PPH now. There's the panic adrenaline rush of obstetrician is totally changed now with the introduction of SR cannula. This is a simple, cost-effective, life-saving, and fertility-saving technique. This is a physical method, does not depend on biological factors for its action. No need to maintain cold chain. For the same reason, it does not fail. Suction cannula system can be organized within 2 minutes time. Bleeding stops just within 2 to 3 minutes. Cannula system works well even in case of coagulation failure. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable, reusable instrument. Helps to reduce maternal mortality due to atonic PPH in low resource settings. Every delivery point in the country should have SR cannula, and it should be used as a first defense, not as a last desperate resort after every other method fails. This is my personal request. No child should become motherless in this country. It is very much possible to achieve PPH death-free country in India. Thank you, thank you, thank you. Jai Hind.
Thank you so much, sir. We would like inputs of our chairperson, Dr. Khyati, on this topic. Dr. Khyati, I can see her name. Dr. Khyati, kindly unmute yourself. Okay. Dr. Shilpi?
Yes, ma'am. Yes, ma'am.
Yes.
Excellent work done by the sir. It's very innovative, very inspiring, and so dedicated about the women's health. And we salute you, sir, and we are blessed to have sir with you. And one question to you. The suction machine, what we are using during surgery is the same or different?
Same machine you can use. Even you can use a manual suction pump.
Okay, sir. And any complication of procedure have you encountered?
No complications at all. Lakhs of applications have undergone in entire South India now. Entire Tamil Nadu and NHM Tamil Nadu has introduced in the entire Tamil Nadu state. Even PHC staff nurses are getting trained in medical colleges. And the government of Tamil Nadu has given me orders for 423 sets to supply these cannulas to every PHC. And PHC doctors and nurses are getting trained now. And I have conducted hands-on training workshop for 63 medical colleges in Tamil Nadu. And all these trained trainers are training their subordinate institutions, and the message is spreading very rapidly. And we are expecting very drastic reduction in MMR in the next coming statistics.
Welcome you, sir, to Gujarat also.
Yeah, I am always ready. I am always ready to come here. But when I am seeing this webinar today, no, I could understand nobody knows much about this. This
I
in Gujarat.
Google and I search and
No,
I
sir,
found your
Gujarat.
videos and everything.
And
Gujarat, we know about it definitely. And since our president is here, Dr. Amita Shah, I would request that we should call sir for the live demonstration also for the same. So we'll take it forward, sir, definitely. And Nadia, then we are all a sister society, so we'll have it together.
No, one thing, if you can come forward, no, I'm ready to do anything. Especially today, I'm concentrating more on Northeast, where MMR is very high. And see, it's a matter of, previously it was very difficult. Now we got the social media, now we got the webinars, we can talk from here, convince from here. Even I'm able to manage operations where I got lots of calls from far away, even from Uttar Pradesh, even Haryana. They call me, sir, bleeding, not able to stop bleeding. And see, from here, I asked them to put on the WhatsApp video, and they'll show me we are able to stop bleeding and save mothers. So the same thing can be done in Gujarat also. Gujarat is a very advanced state and you should take it forward, and I am ready to come.
Thank you so much. Thank you, sir. Thank you for your dedication. Thank you.
And
so much, sir, for such a wonderful session. So you can put your people
hello,
can
shall
buy this. So you
no,
put
no.
your number in the chat box. They can contact
No,
you.
you keep my screen. I put my number there.
Okay.
You put on my screen.
Actually, I wish to communicate that we have done a lot of physical workshop at very, very small places, and they always say that it always works. So just to like enhance your confidence in it, that many people at Muzaffarpur, Patna have been to southern India, that Dr. Perry said that it always works. So, we really look forward that everybody has this SR Canada. So, Babita, we please go ahead with the other session.
No, 1 minute, one minute. Just next slide I'll show you. Just put on my slide. It's not working. Is able to say I put my number there. Anybody can note this.
Ma'am, Shashi ma'am abhi nahi join kar payi to
panel. Yes, panel. Yes, please.
Just this number is here. Anybody can note this number, and they can call me for any help. They can send a WhatsApp message here. Able to see?
Yes, sir. We noted it down.
Yes, you can make a note of this number. Anybody can call me, and they can give a WhatsApp message. We are ready to send cannulas to them and train them online.
So nice of you, sir. So nice of you.
Thank you.
Babita, you can go ahead with the panel.
So Shashi ma'am will join us after some time. We'll have a panel discussion first, followed by video demonstration with Shashi ma'am. I would like to call our moderators for this session. Dr. Abha Rani Sinha ma'am. She is Professor and HOD, SKMC, Medical College, Muzaffarpur. Madam is ICOG Governing Council member, 21-22. She is President of Patna Obs and Gynae Society, 2017. Chairperson of Oxley Quiz Committee from 2015 to 17. Madam is National Corresponding Editor, Jogi, 21-23. She has contributed chapters in Foxy publications and is Master Trainer Foxy EMOC, areas of interest being high-risk pregnancy and vaginal surgery. Madam is MS Signature Awardee 2021. A very warm welcome to you, ma'am.
Thank you.
And a co-moderator for this session, Dr. Maushmi Das Ghosh. She's consultant at Tata Main Hospital, Jamshedpur, Manipal Tata Medical College. She's active member of Jamshedpur Obs and Gynae Society. She has organized first Jharkhand Conference, and she's postgraduate teacher and guide, recipient of awards like Kamini Rao Orator, East Zone and Indumati Javedi Award, and Vani Samanta Award. She has also contributed to Foxy and ICOG publications, and her areas of interest being high-risk obstetrics, adolescent gynecology, minimal invasive surgery, and preventive oncology. As expert panelists, we have today Dr. Archana Dwivedi. She is National Chairperson, IMS Website Committee 2325, President Boggs 2122, and President Founder MSB 2019-20. Her key area of interest being high-risk pregnancy.
Babita, I think we all know each other. We can stop it here without further ado, because panelists.
One line that she is a very, very, very active member. We see her everywhere, and she's a very good dancer also. I appreciate her for that.
Thank you, dear.
Thank you, panelist, Dr. Shailaja Maskar from Valsad. Kindly display CV. Dr. Ami Patel from Baroda. Dr. Jigna from Vapi. Dr. Khanjan Maheshwari from Palanpur. Dr. Gayatri Contractor from Nadiad. And Dr. Geeta Parmar from Nadiad. Kindly display the CV. Saiti, yes. So this year, Dr. Shailaja has a very impressive CV. She is president of Valsad Obs and Gynae Society, and she was past president of Vapi Obs and Gynae Society in the year 2011 and 12. She has presented research papers on amnio infusion, extraperitoneal, laprolift. She's running awareness programs on Beti Bachao, Beti Padhao, and Beti Badhao, adolescent health education and sex education, and child health promoter. A very warm welcome to you. She has, a long CV. We are running short of time.
No, it's okay.
Then we have Dr. Ami Patel. Next CV, Sahiti. Sahiti, please change. Okay. We have Dr. Ami Patel. She's director and founder of Ami Hospital, Vadodara, ex-assistant professor at the Gynae Department of SSG Hospital, Medical College, Baroda. Her areas of interest are infertility and high-risk obstetrics. A very warm welcome. Dr. Jigna Patel, she's consultant gynecologist, infertility consultant, and colposcopist at Natkarni Hospital, Kilapati. She has 18 years of experience and president and secretary of BOGS. She has presented various papers and research articles in journals. A very warm welcome. Next, we have Dr. Khanjan Maheshwari. He's a private practitioner at Agman Women's Hospital, Palanpur. Warm welcome to you. We have Dr. Gayatri. She's a practicing obstetrician gynae since last 25 years at Nadia. And we have Dr. Geeta Palmer. She's director Gopi Clinic. She has a clinical experience of 30 years, practicing since 1994. So we look forward to a great discussion today. I hand over the session to our moderators. And we are waiting for a
Thank you, Dr. Babita. At the outset, I'd like to thank Dr. Sadhna Gupta for bringing us together. And I bring greetings to all the societies from Nadiad, Bapi. Then we have societies from Palanpur, and we have Vadodara. So welcome to all the panelists. And Dr. Moshmi, are you there? I think somebody should ring Dr. Moshmi and tell her that we have started with the panel. I think
I will just give her a call, ma'am. You just
just give her a call because she's there to share the slides.
Okay. Let me call her.
So we had two wonderful lectures, all first by Dr. Sadhna Gupta and the second one by Dr. Samarth. I think PPH cannula, I think it's a really, really good thing. We also have some experience with this cannula and it really works well. So if I may take 2 minutes time to just see whether I can share the slides.
Ma'am, you have the presentation with you?
Yeah, I'm just trying to.
Ma'am, because Moshmi's number is coming busy.
She wants to share the presentation, so I didn't open it, but I'm just doing it. In no time, I'll be doing it.
Till you're downloading, madam, just a point of discussion.
I've already downloaded. Okay. I'll just see whether I'm able to share it or not.
The number you have dialed is currently busy.
There must be a share screen option, madam, down there.
Yeah.
The number you have dialed is currently busy. Please try later.
Is my presentation visible?
No. Yes, ma'am. Yes, ma'am.
Yes. Yeah. Is it visible?
Yes,
okay, good.
Yes, ma'am. Just make it full screen now.
Yeah, I'm making it. So once again, welcome to all the societies of Gujarat who joined for this panel, and we are going to have a panel on obstetric hemorrhage. It is a case-based panel, and I think we all heard the introduction about postpartum hemorrhage. It is one of the major maternal killer, and it has got
it's not in, sorry to disturb, ma'am. It's not in full screen, ma'am.
Is the slide moving?
No, ma'am.
No.
Not moving?
My slides are not yet moving, and it is not full screen also.
Not visible also? Okay.
No, it's visible. Just make it full screen and the slides are not moving.
No, it's visible, madam. Just put it on the show mode.
Okay. Just 1 minute. Give me a minute.
जल्दी join करो. हाँ. Okay. क्योंकि तुमको presentation भी share करना था ना, वो मैम कर रही हैं, लेकिन हाँ. Dr. Moshmi is joining, ma'am. By the time.
Yeah. If I have problem in sharing, then she can take up. Let me see.
Hello, everyone. Dr. Babita, I have joined.
So, ma'am, I've already introduced the
Yeah,
panelists.
no problem. I just wanted to just tell you that I've joined.
Yes.
Yeah. Yeah, Moshmi, you please share the slides, Moshmi. I'm having some problem in sharing the slides. Or I can share. I can try once. Is it visible?
Yes.
Now let me see whether it's moving or not. Not moving, na?
No, ma'am.
Please click on the screen and
Yes, it's moving, ma'am.
now it is moving.
It's moving. Good. So we all know that PPH is responsible for 25 to 30% of all maternal deaths. And it is the definition we all know: any blood loss more than 500 ml during vaginal delivery and more than 1000 ml during C-section. But the qualitative definition is more important, that any amount of blood that causes a deterioration in the maternal condition and which can cause maternal instability or shock. And primary PPH is within 24 hours and secondary is within 24 hours to 12 weeks postpartum. But we must know the importance of the golden hour, because that is the time in which resuscitation must begin to achieve maximum survival with arrest of bleeding. And the first 60 minutes following delivery is the golden hour. And the causes of PPH are the 4 T's: tone, trauma, tissue, thrombin. And as Dr. Sadhna Madam has already emphasized, PPH tests the functioning of health system and the skill of health workers. And in most of the cases, it is unpredicted and it can present suddenly like a thunderbolt. And the patient can deteriorate very rapidly after onset of PPH and even can die in short span. So obstetric hysterectomy, admission to ICU, massive blood transfusion, they are all classified category of SAMM, that is sudden acute maternal morbidity. With this background, we now begin with our first case. She's a 38-year-old primary gravida, DCDA twins, conceived after IVF treatment. She was admitted in labor at 35 weeks, 2 days gestation. On examination around 9:30 p.m., when pelvic examination was done, her cervix was fully effaced, os was 3 centimeter dilated, Leica was thick meconium, the head was at -2 station, the pelvis was adequate, and on bedside ultrasound, we could see 2 live fetuses, first cephalic, second was in transverse live, placenta was fundal, weight of the 2 fetuses were 2.1 and 2.3 kg respectively. LSCS was done at 10 p.m. and the intraoperative period was uneventful, both babies active. So now in this case, since she's a twin pregnancy, what preventive measures will you take? Dr. Khanjan? Dr. Khanjan, can you hear me? Dr. Shailaja, can you take up?
Yeah, definitely, ma'am. I think this patient, she is a high-risk patient in the sense that her age is more 38 years, as well as she is having twin pregnancy. So there are more chances of atonic PPH in this patient. So we need to arrange at least reserve blood for this type of patient, because these are high risk patients. And along with this, we need to give proper uterotonic immediately after delivery, and we are having a certain protocol to follow for high risk patient as well as all type of patient after the deliveries. So even whenever the doctor leaves the room or hospital, then even the paramedical staff can also follow this patient properly. So every time we always say them, those who are at high risk, we don't give head low position. Many a time in many hospitals, they give head low position and vagina can accumulate more than 2 liters of blood and then it trickles out. Then we can use means all the this preventive aspects
What
of
is your protocol
uterotonics intra means during
what
surgery we
AMSL
give.
what AMSL do you practice? Active management
We
of solid state
usually
of
give oxytocin 10 units and in high risk now we are giving carbetocin 100
Yes.
microgram IV slowly over 1 minute. So it will help to retain the contraction of the uterus for longer time, even after we live around
Yes.
4 to 6 hours. So that is very beneficial. And we put misoprostol 600 regularly in the rectum, as well as we always tell our staff to monitor the patient properly for the bleeding, temperature, pulse, blood pressure, as well as the where the uterine fundus is lying after delivery, and we mark it immediately over the abdomen with the marker, so then they can follow if it is gone up or not. And we always tell them to massage the uterus whenever they go to see the patient. And we have a particular protocol after delivery. We look after these patients every 15 minutes for at least 2 hours, then half an hourly for 2 hours. So main 4 hours are gone. Yeah, in that we need to see these all the patients frequently. And we always take care to remove the placenta only after uterus is contracted. Many a time in cesarean section, people are in hurry to remove the placenta manually just to deliver and close the uterus very fast. But we always say don't remove manually, just do the massage and just allow the uterus to contract and let the placenta separate it nicely.
So the
And then
placenta,
see for whether there is anything is written or
in
not.
sections, the placenta should be removed by controlled contraction. I think this message should go that as you remove the placenta in normal delivery after the uterus is contracted, and by applying controlled contraction, the same thing should be followed even for C-section, and that prevents PPH. Very well said. I think all your points are well taken. Now, what happens? The sister is called for PPH. The patient has pallor. By this time, her pulse rate was raised 130 per minute. BP was 100/70. Uterus was atonic. She was passing clots. Bedsheet was partly soaked with blood. So now, Dr. Ami, are you there?
Yes, ma'am, I'm there.
Yeah. So
am I audible?
What will be your approach to manage this patient now?
This patient, she is having tachycardia, hypotension, and she has started bleeding. The uterus is atonic. So first of all, I'll call for extra help. A senior obstetrician should be called for. I'll start resuscitation simultaneously along with atonic agents. Depending on the availability, we can either give carboprost 250 microgram intramuscularly. We can also start her on pitocin drip, 20 units in running pint of ringal lactate, and tranexamic acid 1 gram can be given if required. If bleeding stops and patient is stable, if she is pale, we can transfuse her with packed red blood cells. In spite of all these uterotonic agents and everything, if the patient continues bleeding, then without wasting much time, we should take her in the operation theater for further treatment.
Okay, so that's the initial treatment that you'll give. You have told everything. We should also send the blood for CBC and coagulation screen. At least we can do the bedside blood coagulation test, because then we can get an idea of early any coagulation failure or any blood clotting disorder. And tranexamic acid is one thing which should be given early, because this is what has come in the recent trials, in the recent women's trial, that tranexamic acid works good if you give it early, that is within 1 hour. So it is always good to give tranexamic acid early. And the important thing is that in all the labor rooms, the protocols and the algorithms, they should be displayed, because in a hurry or in what happens when you're in a panic situation, at least you can look at the algorithms and you can follow one after another so that you don't miss anything out. Now, these days we have the concept of bundle approach. Can anyone speak about the PPH bundle approach, Dr. Khanjan? Or Dr.
No, I don't know.
Dr. Archana Dwivedi, she's an expert. Any about the bundle approach?
Actually, it's a long lecture on that, but as we know that we have to be prepared with everything. First of all, the staff, as you rightly said, should be trained for observing the patient, and bundle approach comes with the oxytocins, looking at the amount of bleeding, supplementing the patient, and there is a we try to NSAG training is also given to the staff and this thing, so that we tie the NSAG garment in a proper way and monitor the patient accordingly till the blood products and everything is ready. So, and as you rightly pointed about the placenta, look for the tissue trauma, and it has to be a combined approach. I mean, it's a full lecture on that, but everybody should know about the NSAG garment and its use. So that is very helpful till we ship the patient to the tertiary care center.
Perfect. So what we understand is when we have this bundle approach, we know we do a coordinated approach. Like if we are going for the management of atony, we know this thing has to be done. That is we have to give oxytocin, we have to give uterine massage. So all these things, they are known as the bundle approach. And different uterotonics, I think we all know that oxytocin is the first line medication, but cold chain has to be maintained. Misoprostol is good for our country, especially for the temperature that usually it is a tropical country and most of the time the temperature is high. So there's no chance of losing the potency. Ergometrin, well, though we have used it in our early days, but definitely it has to be used with caution in patients with cardiac disease or hypertensive disorders. Carboprost, one side effect, one contraindication, one has always to remember, that is asthma. And these patients, they may sometimes have intractable nausea, vomiting, and diarrhea. Oxytocin plus ergometrin, though recommended by many bodies, but unfortunately, we don't have it. So now with this patient, she had an estimated blood loss with 1000 ml. She received 2 packed cells. She had injection oxytocin 20 units, along with that carboprost, misoprost, trenexa, and even an intrauterine balloon tamponade was done. How many of you are practicing intrauterine balloon tamponade? I think most of us. Anybody can share her or his experience about intrauterine balloon tamponade? So none of you are using it. Okay, but that works good. Before taking up the patient.
A couple of times, not, I would say that it has been a luxury to have it. Science-Taken's balloon we have in our tertiary care center, but actually it is a life-saving measure, and in few cases wherever I have used, it has been very helpful, because till the help arises, we call for help, but everything takes some time to occur. So by that time, intrauterine balloon tamponade buys us some time while our oxytocin act and other things, measures are being arranged.
Bakri balloon is very expensive, but these days we have innovative balloons. What is available in India also, like which is, or otherwise we can just prepare one with a Foley's catheter or a Chhattisgarh balloon. They all are cost-effective methods. So we should definitely try some tamponade before proceeding with the next step. Now again at 2:30 a.m. the system was called for PPH, pallor increased, pulse rate was further raised. Now the BP started falling further, uterus was atonic, blood loss was increased. Now what next, Dr. Geeta?
Yes, now patient is having a major PPH. I can say now put we can in that category. And first of all, we have to make. Can I is audible to you, everybody?
Yeah, Dr. Geeta, you're very much audible.
Okay. Now we have to make a team management. So we have to first call everybody like obstetrician, anesthetist, intensivist, pathologist. We have to manage for further blood transfusion. And first of all, I can say we have to inform each and every step of the complication of the and management to the relatives. I will counsel the relatives. Okay, this is the condition. Patient is getting serious. We are managing. So nowadays it is very much important to keep the patient what happened condition. So and we have to take in a OT and we have to explore again. So we have to do the laparotomy. And we have to either go for arterial ligation, internal iliac ligation, and then we will see the further after seeing the internal iliac ligation, what happened, whether she is improving or not.
One point I would like to mention here that you do it step by step. That is, initially you do compression sutures, then you go for selective uterine vascularization. But sometimes the bleeding is so intractable that you have to even do a hysterectomy. So always counsel the patient, take an organ removal bond from before, and don't make it very late for hysterectomy. Sometimes by the time we do a hysterectomy, it's too late, and then we may lose the patient. So we have to take a very judicious decision. I think that is the most critical point where we have to take a decision whether to do a hysterectomy or not. And of course, if the patient is bleeding very heavily, then you have to inform your blood bank, because then we have to have the massive transfusion protocol. So initially we try the conservative measures, and if these do not work, then we go for and will skill and drill. I think that is the most important component. You should remember this mnemonic hemostasis, that first ask for help, then A is assess vitals, blood loss and resuscitate. E is establish etiology and treat accordingly. M is massage uterus. O is oxytocin infusion and medical management. S is shock garment and shift to a higher center if you are in a low center like a PHC or something. But if you're in a higher center, you don't need to shift the patient. Then tamponade balloon. A for apply compression sutures. S for systematic pelvic devascularization, that is first uterine, ovarian and internal iliac. Interventional radiologists, if facilities exist, I think in order to save the uterus, at times we can go for uterine artery embolization. But I don't think all tertiary centers, they have this facility. But if you have, you can go for it. And finally, the last resort will be a subtotal or total hysterectomy. I think we have done with the atonic PPH, and now it's my pleasure to call upon Dr. Moushami to take up the second case. Moushami, please.
Thank you, madam. Good evening, everybody. So coming to the second case, she's a gravida 3 para 2 with 2 previous cesarean section. She was referred to a higher center by a private practitioner with a report of anterior placenta previa at 36 weeks gestation. She's a known case of beta thalassemia minor. Her hemoglobin level was 7 g/%. She's a case of gestational diabetes mellitus on tablet metformin. So ultrasound, which was done at the higher center, which revealed a cephalic fetus of 2.7 kg, A5 11 cm, placental tissue across the myometrium, and retroplacental myometrial thickness less than 1 mm, and color flow Doppler showed turbulent lacunar blood flow. Next slide, please. Yeah. So this is the ultrasound picture with color Doppler. So can I request Dr. Gayatri? Dr. Gayatri, so madam, can you tell us what is the diagnosis?
I think Dr. Geeta is there, Dr. Gayatri.
Yeah, Dr. Geeta, madam, what is the diagnosis?
Yes. In this case, I can say this is a case of placenta accreta. Myometrium is involved.
Yeah. So as we have seen, ultrasound with color Doppler has been done. So any other test you would suggest for the diagnosis or for confirming diagnosis?
Yes, MRI we can go for.
Okay. So, Dr. Maheshwari, Dr. Khanjan Maheshwari, would you come in? Dr. Khanjan Maheshwari, you are visible but not audible. So, ultrasound with color Doppler. Next slide, please. Ultrasound with color Doppler is actually enough for the diagnosis. MRI is only done in very doubtful cases where there is a diagnostic dilemma. The cases where the depth of invasion, or in cases where the diagnosis with ultrasound is not clear. Next slide. So now in this case, so diagnosis of placenta accreta has been done. The gestation age is now 36 weeks. So how do we plan cesarean section in this case? So Dr. Shailaja?
Yeah, I think this type of the patient should be taken in the tertiary center where there is a ICCU facility in the same complex. We need to arrange blood as well as fresh frozen plasma. We need to inquire about the availability of everything because patient is having 7 grams of hemoglobin as well as placenta. I think increta is there. And we need to inform the anesthetists also about the high risk factor. We need to take help of our other colleagues to help us. And we need to inform the staff also for those all the things.
Yeah. So optimizing the timing is very important.
I think this is what we have seen is that blood vessels are very near to urinary bladder. So there are chances that these vessels may have gone into the bladder also. So we may need to inform our urologist colleague and surgeon also for this.
Yeah. Yes, very well said. So we have to try that these cases should be done in a routine manner, in a planned way, and avoid having emergency cesarean section in these cases. So the timing of delivery has to be best balanced so that we avoid fetal maturity and also the risk of unscheduled delivery. And as you have rightly said, it is cared by a multidisciplinary team in a center with expertise where there is a senior obstetrician, preoperative anesthesia facility is there, neonatologist is there, blood bank is available, urologist is available, and critical care team is important because these cases will need a post-operative hysterectomy in maximum cases. So the baby must, when we are removing the uterus in these cases, the baby must get the best of its care. So a proper neonatal ICU is very important in these cases. Next slide, please. So steroid cover, we are doing this slightly preterm. So we need to give a steroid cover. Yes, we need to correct anemia. In this case, she's a case of beta thalassemia minor. Preoperative hemoglobin can be corrected. Blood and blood products should be available in hand. And then with proper preoperative counseling and consent, we should go ahead with the surgery because these cases are prone to massive obstetric hemorrhage and consent for multiple blood transfusion, risk of damage to ureter, risk of damage to urinary bladder, and hysterectomy. These should be explained to the patient and family with proper consent and counseling. We should go ahead with the surgery. The patient should understand that with hysterectomy, she will stop having her periods and stop the childbearing. So all these terms should be explained, and with proper consent, we should go ahead with the surgery. And a level 2 critical care bed should be available to take care of these patients in the post-operative period. So we do a wonderful surgery, but post-operative care, blood transfusion is very important for these patients. So a proper critical care team is very important to have a good and favorable outcome. Next slide, please. Yes. So the anesthesia, the choice of anesthesia is sometimes regional. They give epidural combined with GA or simple GA. Cesarean hysterectomy with placenta left in situ is done after delivery. The choice of skin incision again varies. Some surgeons prefer a transverse incision, some surgeons prefer a vertical incision. And these patients need total hysterectomy because if we leave behind the lower segment, there again is a tendency to bleed. So we will end up having a hysterectomy and the patient coming with bleeding. So then we are answerable for such cases. So close monitoring of volume status, urine output, and ongoing blood loss and overall hemodynamics is important. As said, critical care services should be available post-operatively, and blood transfusion should be given in the ratio of 1:1:1. That is RBC, FFP, and platelets. Next slide, please. So in this case was rightly diagnosed preoperatively. So Dr. Patel, Dr. Ami Patel is there?
Yes, ma'am.
Yeah. So can you please tell us, can we avoid having such cases on the OT table? So how do we ensure such diagnosis in the antenatal period?
There are certain risk factors for placenta accreta spectrum disorders. So if we have a patient with placenta previa and a previous uterine scar, say previous 1 or previous 2 cesarean section, or a patient with previous myomectomy and anterior placenta, or if the patient has history of submucous fibrosis which can lead to adherent placenta, then such patients are high risk patients for abnormally adherent placenta. So in such patients, we should ask specifically on ultrasound to look for adherent placenta. So ultrasound has a sensitivity of around 94% for diagnosing placenta accreta. On ultrasound, there is a loss of the retroplacental hypoechoic space, which is normally present when the placenta is not adherent. There is also thinning of this hypoechoic retroplacental zone. There can be presence of multiple placental lakes because of abnormal vascularity. And in case of placenta percreta, there can even be thinning of the uterine serosa and the bladder wall complex. Even involvement of surrounding pelvic structures can be seen on ultrasound. If ultrasound is not able to establish the diagnosis, or if it is inconclusive, the radiologist is not confident whether it is accreta or not, then in such cases we should not hesitate to go for an MRI. Because MRI will establish the diagnosis correctly, and usually it correlates with the surgical findings also.
Yeah, so very correctly said. So all this case was rightly referred by the private practitioner to the Apex Center at the correct time. So similarly, we have to be smart enough to pick up cases who can land up in placenta accreta in the antenatal period. So with every cesarean section rate, the risk of placenta with accreta increases. So as you can see the statistics, with placenta previa and increasing number of cesarean section, the risk of placenta accreta is 3%, 11%, 40%, 61%, and 67% with first, second, third, fourth, and fifth cesarean section. So it has to be diagnosed in the antenatal period. And if we diagnose intraoperatively on the OT table, then, and if we are not well equipped with the expertise or with blood transfusion or with help, then it is always possible that we close the abdomen without delivering the baby and refer the patient to a higher center where she will be adequately taken care of.
Ma'am, hello.
Yes, Dr. Khanjan.
I want to add 3-4 things in this.
Yes,
during operative time, it should be always vertical incision on abdomen, because you do not know up to what extent you have to go during operative. Second, before delivery of the baby, you should dissect the bladder adequately. So you do not waste time during the time of bleeding to dissect the bladder. Number 3, you should always keep 2 things in your emergency drum, routine drum, that is right angle forceps for intrailiac artery ligation. Second is Satinsky forceps used by urologists during nephrectomy. When you apply it in the broad ligament, it crushes, it occupies, occludes most of the major blood vessels. So your hysterectomy would be rather bloodless, and during bloody situation, you are rather will damage the ureteric structures and all like that. Or you can also use that bulldog clamp to apply on the common iliac artery. We use it routinely during placenta accreta syndrome. And you can also think of pre-operative ureteric stenting in this kind of patients.
Okay. Dr. Archana.
I think I agree with whatever doctor said, that you should be ready with everything. You cannot leave it. But sometimes it is a very tricky situation because we get to do the sonographies at peripheries, and sometimes ultrasound quality may not be very good. And there was one case which I encountered. It was a placenta percreta and it was placental perforation at the fundus. So whenever you're dealing with infertility cases, especially those who have been undergone hysteroscopy, even IVF, so those cases also should start ringing a bell in your ears that they are high risk and prone. And you have very well said that it has to be preparation ahead along with the hysterectomy, and still the consent is very, very important, and counseling of the relatives as a mob, not just the patient and the husband. So I think MRI is a very useful tool when you're into a confusion, especially on the posterior part, because diagnosing is very important, but missing a diagnosis lands us into a soup at the OT table. So that should not happen in this modern era. And rightly said that the sinuses control the instruments, as Sir has highlighted, it has to be well prepared.
Yeah.
And incision on uterus should be on upper part. You should not disturb the placenta.
Yes, the incision should be planned in such a way that it should be above the upper margin of the placenta.
Yeah, and
so
without disturbing the placenta, you can start the hysterectomy.
Yes, so that
and taking the sutures across the lower segment in a circular fashion, and then purse string sutures also sometimes tends to close the placental sinuses, and we are helped and we can save their lives.
Yeah, thank you so much. So for the next case, Madam Dr. Abharani Sinha will take it.
So it was a very good discussion about placenta accreta, and all the tips given by Dr. Khanjan were also very good. I think dissecting the bladder before the taking of the baby, I think that was a very useful tip, because in panic when you're doing a hysterectomy and then you waste your time dissecting out the bladder and going down. So that was wonderful. So now we come to the case 3. And she's a 28-year-old G3 para 2 L2. She had a previous normal vaginal delivery. She was admitted in labor room at 38 weeks gestation in active labor. The course of her current pregnancy was unremarkable. Labor progressed normally, and the patient spontaneously delivered a 3.6 kg boy. There was no vaginal or perineal tears. The first and second stages of labor lasted approximately 4 hours and 30 minutes. The placenta was delivered complete with minimal blood loss. The patient was transferred to the maternity unit 2 hours after delivery with a normally contracted uterus and without any evidence of abnormal blood loss. But 4 hours following delivery, the patient complained of severe perineal and abdominal pain, along with she could not void urine. She looked pale, pulse was 100 beats per minute, BP was 100/60. Uterus was well contracted and felt at the level of umbilicus, but the right lower quadrant was extremely tender on palpation. On pelvic examination, no obvious vaginal or vulval swelling. On PR examination, no bogey mass felt, but the patient's vitals deteriorated further. The hemoglobin was now 7.5 gram% from 12 grams, which was noted earlier, and an urgent transabdominal sonography was done. And what we saw was a hypoechoic mass of 9 into 4 centimeters on the right side with a well-contracted uterus, which was deviated to left. So Dr. Gayatri, what is your diagnosis? Dr. Shailaja, anyone can take it.
Yeah,
Dr. Geeta is there, ma'am.
This is yes, I'm there. Yeah. This is a post-partum delivery. Patient is in a hemorrhagic shock, and the ultrasound is showing this mass is suggestive of the broad ligament hematoma. So we have to.
This is uterine rupture.
Okay.
Or cervical tear extending up to the uterine region.
Yes, but in this case, there was no tear. At the time of admission, there was no tear.
So I think finding is going more towards broad ligament hematoma.
Yes, this was the case of broad ligament hematoma. Though normally after vaginal delivery, we rarely find broad ligament hematoma, but these are usually the result of upper vaginal, cervical or uterine laceration, which extends into the uterine or vaginal artery. So rapid labor, in this case, we saw her duration of labor was 4 hours and 30 minutes. Yeah, cesarean
Everything
section,
happens first.
instrumental
It
deliveries,
is precipitate labor.
Precipitate labor. They are the predisposing factors in the formation of broad ligament. So now anyone can take it. How do you manage a case of broad ligament hematoma once you have diagnosed?
Once after the diagnosis, we need to explain everything to the relatives as well as patient. We need to take written consent, including up to the needed hysterectomy also. We need to plan proper PCV as well as FFP if needed. And then we need to do laparotomy with vertical incision on the abdomen, as well as we need to just open the broad ligament just near, and we need to first we do just close suture the uterine vessels. Because in this case, in broad ligament, many a time we cannot reach up to the internal iliac. So uterine vessels as well as the ovarian vessels on the same side, and the descending cervical vessels, we need to close everything, and then we look for the whether the hematoma is increasing or not. If needed, then we need to remove that blood clot also, and then see whether the bleeding is still occurring or not. If there is no active bleeding with all these things, then we need not to go for the further treatment. Or if it is still bleeding, then even we can externalize the uterus, and many a time it is very nice to go to approach the internal iliac arteries from the back side of the uterus whenever there is a broad ligament hematoma. So touch the promontory and then go on that side and see the bifurcation, and do the internal iliac ligation also. But it is from the back side of the uterus,
Posterior
not through
approach.
that
Approach.
posterior side aspect of the uterus.
Dr. Khanjan, can you share any of your experience? Dr. Khanjan?
Somebody has said that it may be uterine rupture. Of course, it may be uterine rupture even after normal delivery has occurred.
Yes.
And if there is torrential bleeding and uterus is in normal tone, so you have to think about traumatic PPH and broad ligament hematoma and uterine rupture. Most of the time, hysterectomy does the job, but during finding the source of the bleeding, you may injure the ureteric tract. So internal iliac artery ligation is the better option. And as ma'am has said, the posterior approach from the promontory, you have to trace the internal iliac from the posterior approach, from common iliac to bifurcation and ureter, and you have to trace from the posterior approach of the internal iliac artery. And you, after ligating the internal iliac, your job is done normally.
Okay. So we all know that diagnosis is based on the clinical impression of internal habit, because externally the patient is not bleeding, but she starts looking pale and her hemoglobin drops. So if we find a persistent postpartum pain together with shock, elevated uterus fundus, and a unilateral fluctuating mass, then we should suspect a broad ligament hematoma. Rapid diagnosis is very important, because sometimes even large hematomas can evade adequate assessment. I think imaging is one very important thing. These days with ultrasound in the labor room, I think we can diagnose it early, and treatment is conservative management only for very small hematomas. With this big hematoma, it is always, you should do a laparotomy, and depending on the situation, you can go either for internal iliac artery ligation or hysterectomy, and it also depends upon the patient's hemodynamic status. In this condition, a decision of exploratory laparotomy was done. Patient's coagulation status was assessed, blood products were arranged. Here the hematoma was found in the right broad ligament, the right paracolic gutter posteriorly, and space of resius anteriorly. Normally, what we have found, whatever few cases we have seen in our clinical practice, the bleeders are not easily identified. So in most of the cases, we have to do a subtotal. Subtotal hysterectomy will work in these cases. We need not go up to the lower segment in these cases. So in this case, hematoma was non-expanding, hence left undisturbed, and intraperitoneal drains placed in situ. 3 units of packed cell were transfused. Post-operatively, patient was managed in high dependency unit. Catheter was removed after 2 days, and then the patient's stitches were removed on day 10, and she was discharged. Now, with the fourth case, may I request Dr. Moshimi to take up?
So welcome back. Welcome to the fourth case scenario. So she's a gravida 3 para 0 abortion 2. This patient was admitted in active labor at 37 weeks. It was a cephalic presentation with clear liquor and an average size baby. Blood pressure was normal. Now investigations revealed hemoglobin of 9 gram%. Now this patient has jaundice with serum bilirubin of 7.3, direct bilirubin 5.9, enzymes were raised, PTINR is 1.5, platelet is 1.2, and serology negative, and blood sugar within normal limits. So what is the possible diagnosis? And what prophylactic steps can be taken in this case to minimize the risk of PPH? She's already in labor. So what prophylactic steps need to be taken? So anybody who wants to come in?
3 differentials in third trimesters for jaundice. One
Dr.
is
Khanjan, yes.
One is HELP syndrome. Second is AFLP. Third is viral.
She's normotensive.
She's
So I am ruling out one by one.
Yes.
She is normotensive. The HELP is mostly ruled out, but it is not the must get. Normotensive patients cannot get HELP. So I will be ruling out HELP number 1. Number 2 is AFLP. But she may be a AFLP case. Blood sugar are normally they shows some episodes of hypoglycemia. So AFLP is number 1 diagnosis, and serology is negative. So viral hepatitis markers has been sent. Hello.
Yes, you're audible. Please carry on.
Viral hepatitis markers should be sent, and if she is hepatitis A or
viral hepatitis is negative.
Serology negative. So
Serology
mostly she sets in the AFLP, that is acute fatty liver of pregnancy. And
next slide, please.
Next slide.
Madam, next slide, please.
Oh, sorry. Yes.
Yeah. So as very well said, Dr. Khanjan. So when we are ruling out the causes, so blood pressure is normal, but it can be a preeclampsia associated cause, or it can be not associated with preeclampsia, or it can be simple causes which are coincidental with pregnancy. Next slide, please. Yes. So now this patient who is already in labor, this patient has risks of high maternal and perinatal mortality. We all know.
Very high.
So keeping cross-matched packed cell in hand is very important. We can transfuse fresh frozen plasma prior to delivery and in the peripartum period to correct her coagulopathy. Injection vitamin K, we all know, 10 milligram. And we should prefer and encourage for vaginal delivery and avoid taking her up for cesarean section for trivial reasons like maybe CDMR or something. Anybody who else would like to come in?
And she should be delivered in a tertiary care center.
Yes.
And not at a private maternity home with a single solo doctor.
Yes.
And the maternal mortality is
even if she is in active labor, she should be referred.
So patient and relatives should be counseled and informed, and written consent must be taken for explanation. We have explained them about the high rate of maternal mortality in such cases even after delivery during the labor also.
Yes.
Ma'am, AFLP cases deteriorates within hours. It will won't give you
very
days,
fast.
So patient is stable in morning. She can be anuric in the evening. So you should not wait more for the normal delivery, number 1. Second, fresh frozen plasma should be given prior to the cesarean section. Third, hypoglycemia is the major cause of that hypoglycemic encephalopathy and mortality in this kind of patient. So in intensive care, sugar should be monitored very judiciously.
Yeah. Ma'am, one slide prior, one slide back.
Okay, sure. Is it visible now?
Yes, ma'am. Just a slide back.
Sure. Not moving? Wait, let me share again.
I'm enjoying the panel thoroughly. It's such a nice discussion going on.
Moshmi, can you see the screen?
Yes, ma'am. Screen is visible. Yes.
Okay.
Yes.
Now it's okay?
Yeah, ma'am, you have to go 2 slides before.
Okay, sorry. Okay, now it's okay?
Yes. Next slide. Yes. Now this patient, as rightly said, we had expedited her delivery and she had an instrumental delivery with repair of episiotomy. We have given her fresh frozen plasma. We have given her injection vitamin K. But again, after 3 hours, there is increasing pallor with tachycardia, blood pressure 90/60. Uterus is well contracted and ABG shows hemoglobin of 4.2 gram%. So how do we manage this case?
First, we'll see and find out the cause of pallor and why the hemoglobin has fallen down so much, and there are more chances of trauma because there is no outside bleeding that we can see in this patient, and explore the genital tract properly and see, and if it is any tear is there, then find out and suture it properly, as well as manage the blood, give the blood to this patient, as well as go for the again clotting factor assessment, and give the fresh frozen plasma again if needed, and meanwhile maintain her hydration as well as glucose level during this procedure.
Yes. So on examination of this patient had a large vaginal wall hematoma. So even after taking full care, so now in this case, what we mean to say is that there can be simultaneously there can be 2 causes of PPH. So our focus was on jaundice, on correcting her coagulation. But now this patient again had a traumatic PPH. There was a large vaginal wall hematoma because it was repaired by a junior doctor. There was a tear opposite to the side of episiotomy, which was missed. So this patient again had evacuation with layer closure, followed by vaginal packing, and a drain was given. Next slide, please. So this traumatic PPH following vaginal delivery can be due to various causes like extension of episiotomy, perineal tear, paraurethral tear, or vaginal lacerations. So change in vital signs, and also the signs will be disproportionate to the amount of blood loss. In these cases, IND, we all know, incision and evacuation should be done under proper light with proper exposure, preferably in OT. And bleeding vessels ligated, and sometimes bleeding vessels cannot be found. So in case of diffuse oozing, layer closure is done with proper hemostasis and eliminating dead space. So any expert comments on this? Anybody would like to come in? So this was a case of jaundice who was managed and then had a vaginal delivery and then had a traumatic cause of PPH.
So very excellent case, I would say. It is full of challenges. I know you people have handled it very nicely. The only thing is that we have to train our junior doctors and staff also to look for the bleeding, and we should not have a delay in draining this hematoma because atrophic necrotic changes, adjacent organs are affected sometimes. So if it is neglected, it can be a real nightmare for us.
I want to add one thing. What is your experience? I don't know, but we have frequently seen that whenever we are not finding the bleeding point, at that time, just putting Botro clot on sterile gauze and pressing it for a few minutes, and majority of blood excessive bleeding has stopped. So that will be also helpful in this case, and then we suture layer by layer just to stop, and we need to take care to not to keep any dead space in this.
Yes. So for the next case, I would request Abha madam to come up, please.
Yeah, thank you, Moshmi. And I think your last case was very challenging, and I think it is a nightmare for all obstetricians if we get a case of PPH with a normal liver function test. I think that is real nightmare. And at times we have been really caught up in very bad situation in those type of cases. So now this is the last case, and this is a case which has been shared by Dr. Sadhna Gupta madam only. And this case, I have just put up this case because it is an unusual case. She is a third gravida with previous 2 sections who had an elective section at a tertiary hospital. She had uneventful recovery beside having low-grade fever. After 10 days of C-section, she had excessive bleeding with signs of shock, and there she was managed with standard care like with antibiotics, blood. And in that case, when ultrasound was done, it was within normal tissue limit with no placental tissue. The patient took a second opinion in 7 days. She was again reassured at the higher centers, but after 7 days, she had a life-threatening bleeding.
Ma'am, there is a voice break. Abha madam? Abha madam, there is a voice break.
Sorry, we can't hear you, ma'am. Moshmi, you can continue till ma'am joins.
Yeah. So this patient who had PPH took second opinion in the next 7 days, and she was referred to a higher center. So this patient, she received antibiotics, she received tranexamic acid. She went on from doctor to doctor, who again reassured her every time. And finally, she landed up in in a second episode of PPH, where she was in shock, hypovolemic shock. She received blood transfusion and finally had a hysterectomy. And during hysterectomy, it was a small infected uterus, which was removed. And then the patient did well. So this was a case of secondary PPH where all conservative measures failed and patient needed a hysterectomy because of a repeated episodes of hypovolemic shock. Abha madam, are you there?
Ma'am is somehow, she's disconnected.
It's okay. So you have completed this case?
Yes, madam.
Yeah, actually the point was to show this case was that sometimes we get such type of unusual cases where we cannot find the cause, and especially if the uterus is very friable. Is the slide visible?
Yes.
Yes, now it is visible.
At this moment, Abhaji, I will just like to intervene. Like wonderful, brilliant case discussion, and Dr. Shashi has also joined. Today, I have an opportunity to have time from Dr. Pankaj Desai for our exclusive interview. So I will be taking leave around 7:45 p.m. I hope Dr. Shashi, I think Moshmi, you can make a little bit short so that Shashi can join. I will be there for another 10 minutes, and I owe at this moment thanks to all dignitaries, office bearers of all the Gujarat societies. Thank you for all the nominations and all the precious wishes. And we look forward to great association. And another legend from Gujarat, Dr. Pankaj Desai, will be with us tomorrow. Please join that program, and I will share recording link for that with the wonderful, incredible journey of Dr. Pankaj Desai also. So I thank you, Dr. Abadi. Just I intervened in between because
thank you, Sadhna ji, and all the best wishes for your future elections, and we all are with you.
Thank you.
All the best.
Thank you.
I think so. We have
Best
almost
wishes,
finished
ma'am.
this case.
So this is the last case. So we are winding up for the.
So we are winding up. So PPH can happen without warning. That's the most important point. So we have to be prepared. We have to have protocols and algorithms displayed in labor room, regular PPH drills. We should have PPH boxes and hemorrhagic cards. We should have swift obstetric judgment. An increasing experience and will to learn from each experience serves only to sharpen one's alertness during this stage. Thank you so much. Thank you, whole team Gujarat and Sadhna ji, for this wonderful opportunity. And Dr. Shashi, thank you for waiting. And I know your presentation will be a very good one. So now the stage is yours, Dr. Shashi.
Thank you so much. It was an excellent panel and I got full opportunity to watch the panel. Wonderful. Abha ma'am, you are always awesome.
Just making a point that our moderators were, very practical and very short, crisp messages. So thank you, ma'am, for making us a part of this.
Thank you, Archana, for being the expert. You added flavor to the panel. Thank you so much.
Thank you, ma'am. Best wishes to Sadhna, ma'am, and over to you.
Yeah, thanks to all the learned panelists. We had a wonderful discussion, and all the best to Sadhna, madam.
And madam, thank you so much because you have included each and all topics of PPH, trauma, retaining tissue, tear, or everything. So all types of PPH are taken in this. So thank you so much for this nice case discussion.
Thank you very much from behalf of the Nadia Foxy. We have revised all the news matter regarding the PPH because we nowadays do not read much more, but by with this such webinar, we refreshes our knowledge and got the newer things that is PPH cannula. That is something interesting and that has to widely spread to each and every places. And thank you very much to all the faculties and ma'am, and we enjoyed this session. Thank you very much.
Thank you very much, madam, from the Palampur Obstetric and Gynec Society. And I enjoyed the webinar and panel discussion. And on the behalf of Palampur Obstetric Society, I would like to invite you, all of you, to the midterm SOGO conference at 30th June at Mount Abu. It would be very wonderful environment at Mount Abu in the rainy season and with good academic feast and enjoyments.
I'm coming, Kanjan, I'm coming. And I was
Yes,
listening to your comments, wonderful comments, and everybody was it was awesome. So I'm looking forward to come to Mount Abu and meet, I think, many people from Gujarat. Thank you.
Welcome, madam. Welcome. Thank you.
Thank you. So it was a wonderful panel. Great work was done by our moderators and our expert panel, and our panelists had some really interesting inputs. So thank you so much, all our panelists, expert panelists, and our moderators. Now moving towards a session on video demonstration by Dr. Shashi Kabra ma'am. And the third topic is stepwise devascularization in PPH. For this, I would like to invite our chairperson, Dr. Dignesh Valakia. Sir is Secretary of Palanpur Obs and Gynae Society and is Director at Ashirwad Hospital, Palanpur. A very warm welcome to you, sir. And second chairperson is Dr. Pooja Agarwal. She is an obstetrician and gynecologist at Pooja Hospital and she is immediate past secretary, WAPI, Obs and Gynae Society. So I hand over the session to our chairpersons to invite and introduce Dr. Shashi ma'am and to conduct the session. So, Dr. They're not there or not? I can't see their names. So, okay, I will do the honors. Let me introduce Shashi ma'am. Talking about Shashi ma'am is always a great pleasure. I've been listening to her talks in so many webinars, ma'am. So, ma'am is DDU Hospital, President Delhi, Gynae Forum Southwest. Madam is Chairperson PCP NDT Committee. She has received IMA Appreciation Award 2018, recipient of Wonderful Foxy Award, Wonder Foxy Award, APJ Abdul Kalam Appreciation Award, IMA WD Karamveer Award, the Champions Award Obstetric Critical Care, APJ Excellence Award, and the Asia GCC Award Quality Leader Healthcare, Rashtriya Gaurav Award. She is National Mentor Lakshya in association with AIMS Delhi, GOI and WHO, and she is member of the Practical Obstetric Committee FOXY and Medical Education Committee FOXY. She has organized 65 workshops on PPH all over India. A very warm welcome to you, ma'am. It is always a pleasure to listen to you.
Yeah, same here, Dr. Babita. Thank you so much for such a kind introduction. And it is really a pleasure. Now we have a long discussion. Hello, everyone. So my sincere thanks to Dr. Sadhna ma'am, Dr. Babita Shukla, Dr. Babita Shukla, Dr. Ayushi Agarwal, and the societies of Baroda, Vapi, Valsad, Nadiad, and Palanpur for giving me this wonderful opportunity. Am I audible?
Yeah.
Yeah. So the first line which I always say whenever I take any talk on PPH is that convert your nightmare to an expertise. So this we will learn. We can do only by learning the skills and drills. So this nightmare word should be omitted from our dictionary and to be replaced by the word expertise. So since it is a video session only for 10 minutes, so quickly I'm going through this picture. You can see here, this is the LSCS hysterectomy incision, and these are the places for uterine artery ligation, one proximal and one distal. And this is another place, which is the place for ligation of the anastomosis of uterine and ovarian artery. Every time I say that the position of this ligation is at the medial end of the insertion of the ovarian ligament, and it is not here. The word ovarian artery ligation is a misnomer. It is not here, it is here. We actually ligate the anastomosis between the two vessels. So showing you uterine artery ligation. Is my video running?
Yeah, ma'am.
So the bladder has been pushed below, and I'm palpating the uterine artery. The suture material which I use here is number 1 chromic catgut or number 1 vicryl. Even 10 vicryl will do. Taking 2 centimeter of the myometrium, 2 centimeter below the uterine incision. Getting the needle from anterior to posterior. Remember, this first bite has a part of myometrium. Then fan out the broad ligament, find out a avascular area, and go from posterior to anterior through the avascular area. Now look at the knot. 2 turns in the first row to make it a surgical knot. Then each second knot in reverse direction. This is the distal ligation, 2 to 3 centimeter below the proximal one. Technique is same. Take a part of the myometrium, go from anterior to posterior. Fan out the broad ligament. Look for an avascular area. Go from posterior to anterior. Take care not to prick the vessels. And tie it in the same manner. So here you can see 2 uterine artery ligatures. We do it bilaterally. So this video is shared by my friend, Dr. Soma Mitra. It's a video on uterine ovarian anastomosis ligation. Part of myometrium is taken, the same suture material I'm using. The bite is here, not here, because here it will cause a lot of bleeding. Going from anterior to posterior, the site of anastomosis is here. So needle coming from posterior to anterior. The anastomosis is in between these two bites. And this is how ovarian uterine anastomosis ligation is performed. Now coming to the most important part of today's talk, this talk on mine, this is internal iliac artery ligation. FIGO guideline 2022 says that every obstetrician should know internal iliac artery ligation. It is a life-saving procedure. So you can see here, this is abdominal aorta. At the level of L4 and L5, it divides into two common iliac arteries and make an inverted Y. And then again, each common iliac artery divides into external iliac artery and internal iliac artery. And this makes another inverted Y. So we are concerned with these two inverted Ys. This is one side of the picture, the common iliac artery. This is lateral side, this is medial side. It divides into external iliac artery, which is continued as femoral artery below the inguinal ligament, and it divides into internal iliac artery medially, and this internal iliac artery gives a posterior branch as soon as it originates from the common iliac artery. Because this posterior branch supplies only the parietal part, and this anterior division of internal iliac artery supplies the visceral part, and the main branch is uterine artery, vaginal artery, vesical artery. So we have to ligate this. So in a pool of blood, we do not recognize, we cannot see this posterior branch. So how to recognize this site? This part, this proposed site of ligation is 3 to 4 centimeters below the origin of internal iliac artery from the common iliac artery. So I will, so if I look at the folded thumb of my hand, then it is around 4 centimeters. So I just place my thumb and find out the place for ligation. So how internal iliac artery works? Bilateral internal iliac artery results in 85% reduction in pulse pressure, 50% reduction of blood flow. It converts an arterial flow into venous flow and facilitates coagulation. Bleeding is reduced, life is saved. Initially, it is difficult, but one can practice it after 3 to 4 ligations, and the learning curve is not as prolonged as in laparoscopic surgeries. So these are the two instruments, two things which I require for performing an internal iliac artery ligation. This is mixture forceps or right angle forceps. It is bent at right angle, but the tip is not sharp. And this is number 1 silk. If silk is not available, I use Vicry and I just make the thread double. The purpose of making the thread double is that when you cut it here, you can make 2 threads out of 1 thread only. And the advantage is that you pass the mixture forceps from lateral to medial only once, thus decreasing the chances of injury to the great vessels. I don't have to, I think in 10 minutes this conversation. This is a model which was made by me for demonstration to my students. So this is the correct technique, mixture forceps. When we make a dissection between the internal forceps from lateral to medial always, grazing the artery so that it doesn't injure the vein here. And if we do this, this is a wrong technique, then it will hit the external iliac vein of that side. So this is the correct technique. Remember the word that this mixture forceps or right angle forceps is always passed from lateral to medial. Now I'm sharing a case. This was a 26-year-old primary gravida with full-term pregnancy, booked initially in one facility, had ANC at an Anganwadi center. Then she had labor pain on 23rd November 2022 and rushed to 3rd hospital at night. She went into obstructed labor, taken to another 4th private hospital. There she had undergone emergency cesarean section for second stage arrest in spinal anesthesia at 8 a.m. And then she had an episode of PPH at 10:15 a.m., which the doctors managed medically. Then again, she had second episode of postpartum hemorrhage at 12:30 p.m. and she developed shock. So doctors took her to OT, and the saddle block anesthesia, left lateral cervical TA was repaired and the posterior vault repair was done. There she received 4 units of PRBCs, 4 units of FFP and 2 platelets. Then again at 7:15 p.m. she was again found in shock. She was resuscitated and referred to me with 5th unit of PRBC on flow. So by this time, she had already received 11 units of blood. When patient came to me, her pulse was 146 and BP was 104/60. It looks like a normal BP, but look at the shock index, it was 1.4. So I took no time in taking the decision that I have to open the abdomen in this case. So when I opened the abdomen by a preferably by pre-planned longitudinal incision, I could see this broad ligament hematoma, which was extending from the fundus to the wall. So, and the uterine artery was restricted, so I performed the obstetric hysterectomy in this case. But even after doing obstetric hysterectomy, there was oozing and bleeding in the pelvis. So I thought I performed bilateral internal iliac artery ligation in this case, and I'm showing a live video. This is the round ligament pedicle, and below the round ligament pedicle, I'm lifting the peritoneum and cutting it slowly, going up to the lateral pelvic wall, and my direction of dissection is parallel to the infundibulopelvic ligament. This is called retroperitoneum. This is the anterior peritoneum of the broad ligament, and we call it opening the retroperitoneum. This is the retroperitoneum which we open for exposing the great vessels. You can see here that I took care of the great vessels every time I was lifting the peritoneum. Now, after putting all the instruments, I'm just separating the loose ureter tissue with my fingers. This, if I freeze this picture, you see this is the ureter in the medial flap, and this is external iliac artery, this is internal iliac artery, and this is common iliac artery. Making it more prominent, ureter in the medial flap, you can see internal iliac artery, external iliac artery, and common iliac artery. Common iliac artery, internal iliac artery, external iliac artery, and ureter in the medial flap. Making it more prominent only with the movement of fingers. Now you can see and well recognize the inverted Y. Now I am pressing the external iliac artery and palpating for femoral pulse. It goes, and when you remove the pressure, it comes back. Now I am pressing the internal iliac artery and looking for femoral pulse. There will be no change in femoral pulse. This way I recognize the internal iliac artery and confirm the internal iliac artery. Now I am doing a dissection on the sheath which encloses the internal iliac artery and vein. And look at the movement of the forceps. It is parallel to the vessels, not perpendicular. If I make it perpendicular, then it will injure the internal iliac vein below. Look at the dissection. This is the internal iliac vein seen below. And how careful we have to be. Proposed site of ligation, I have already told you. My half thumb length from the origin of common iliac artery. So now the artery has been little sclerotized, and I'm passing the mixture forceps from lateral to medial. As you know that this side is external iliac artery. The loop is already prepared. You see, the loop is already prepared. And very gently, I will get hold of the loop and will take out to the opposite side. Now from this loop, I will make 2 threads. This means only by insertion of right angle forceps only once, I made 2 threads. So definitely, surely the chances of injury to the major structures will decrease. Now very gently, I will separate these threads to see which one is continued with which one. So this is what I'm doing. The right angle forces passes grazing the artery because artery has got thick wall, and the vein, the bigger the vein, the thinner the wall. So that's why you have to graze the artery. Now I've recognized which thread is continued with which one, and I'm applying first knot. You see there are 2 turns in the first knot, a typical surgical knot. And I'm bending my back and head and saluting the artery, and I'm just placing the knot on the top of the artery. One should not pull the artery because it might get torn and come, and there can be massive bleeding. So 3 knots I've applied. It is a very gentle movement. Every time I'm getting my finger inside in the depth of the cavity, bending my back and my head, and very gently I've cut it. Now I'm taking the second thread. The next ligation will be 0.5 to 1 centimeter away from the first one. So I've taken hold of the thread. Again, 2 turns in the first knot. Bend your head and neck. Put the artery on put the knot on the superior surface of the artery. Get your fingers deep inside. Never pull. You can see, you can very well appreciate the bulge between the two sutures, two ligatures. You see here the bulge between two ligatures, and they are 0.5 to 1 centimeter apart. We only apply two ligatures of the internal iliac vein and we never cut it. Remember it. So now my second knot is completed, and I'm cutting the thread very gently. You see, there are two ligatures, 1 and 2, and a bulge between. The external iliac artery is this one. This is internal iliac artery, and here is the ureter. So these are the tips for ligating internal iliac artery, which I have not copied from any of the textbooks. These are my own experiences after performing 104 internal iliac artery ligations in last 22 years. We do internal iliac artery ligation from two approaches. One is posterior approach and one is anterior approach. The method which I have shown in my video is anterior approach, where we open the retroperitoneum from round ligament and extending parallel to the infundibulopelvic ligament. And there is one called posterior approach. There we feel the sacral promontory and we cut the peritoneum 2 centimeter below and 2 centimeter lateral to the sacral promontory on both the sides. And there we will be able to open the retroperitoneal space. Then once you open the retroperitoneum, you have shown in my video, you have seen in my video that we do only finger dissection. I do not use any sharp instruments because it might injure the big great vessels lying there. Then third point, as I've shown you, locate the bifurcation. That means locate the inverted Y. Unless you recognize any structure, you cannot perform any surgery on that. Then next, as I've shown you, recognize internal iliac artery as medial structure which does not cause any change in femoral pulse. This will confirm by two methods. First, by pressing the external iliac artery, as I've shown you, there will be a change in femoral pulse. And when we press the internal iliac artery, there will not be any change in femoral pulse. So doubly confirmed. Now next is movement of mixture or right angle forces. Remember the word lateral to medial, and lateral to medial on both the sides. Whether you are standing on left side or right side, it is always done lateral to medial. However, I myself stand always on the right side of the patient because I am a right-handed person. Then careful not tying in the cavity. Don't pull the threads. Always bend your head, bow your head, and apply the ligature on the superior surface of the artery. The two ligatures should be 0.5 to 1 centimeter apart. And last but not the least, always do bilateral, because the literature says that the chances of free laparotomy and morbidity increases with unilateral internal iliac artery ligation. I have seen many cases worsening, and many of the patients died because of unilateral internal iliac artery ligation. So this is very important to do bilateral internal iliac artery ligation. And you know that the facilities for uterine artery or internal iliac artery embolization are still very less in our country. Not even in Delhi we have more than 3-4 facilities. So it is better that you develop your own skill of performing internal iliac artery ligation, so that you should not become dependent on a operation theater or a specialized place like interventional radiology, or not dependent on a radiologist. So thank you so much for giving me the chance and for listening to me. And with this, I seek your valuable vote for ISOG Governing Council membership elections.
Thank you so much, ma'am. That was a wonderful demonstration and lecture as usual.
Thank you.
And we are, I'm sure everyone will try out, at least in gynae cases, they'll try out internal iliac ligation, so that in an emergency you're really fast and efficient with it. So that was really great. So,
when you are performing,
so Sadhana ma'am had to leave because she has some other session going on with Dr. Pankaj Desai. She had extended her thanks to all the president and secretaries of Baroda, Valsad, Vapi, Nadyad and Palanpur societies. Ma'am is seeking your blessings She's Foxy Presidential Candidate 2023. So it will be really nice if all of you like support Sadhana Madam and promote her in your societies. We'll be really thankful to you. Now coming to the official vote of thanks, we are really thankful to our key organizer, Dr. Sadhana Gupta, Foxy Presidential Candidate 2023, and our chief guest, Dr. Vineet Mishra and Dr. Deepak Bhagde, Dr. Guest of Honor, Dr. Geetendra Sharma. We are thankful to all our speakers, Dr. Sadhana Ma'am, Dr. Samarth Ram, Dr. Shashi Kabra Ma'am. Their lectures were really wonderful. And the chairpersons for the session, Dr. Amita Shah, Dr. Paresh Parmar, Dr. Khyati, Dr. Shilpi, Dr. Dignesh Bhalakia, and Dr. Pooja Agarwal for conducting the session so very smoothly. Our sincerest thanks to our moderator, Dr. Abharani Sinha and Dr. Maushmi Das Ghosh for moderating the session with such wonderful cases. And of course, our thanks to expert panelist, Dr. Arshina Dwivedi. Our panelists were really good. They gave some really interesting inputs. Thanks to Dr. Shailaja, Dr. Ami Patel, Dr. Jigna, Dr. Khanjan Maheshwari, Dr. Gayatri, and Dr. Geeta Parmar. Thank you, everyone. Not to forget my co-moderator, Dr. Ayushi, and the IT team, Sahiti and Tulika Tripathi. And last of all, we should never forget the audience, because if the audience are now there, who will be there to listen to our talks? So thank you, everyone, once again from the side of Sadhana Ma'am.